Good evening, everyone, one and all, not just members of Maharashtra Ophthalmic Society, but the All India Ophthalmic Society and all our other colleagues who are watching around the country. I am Dr. Piyush Bansal, Chairman of the Scientific Committee of MOS, and I take immense pride in welcoming you to the first webinar of this year from the Maharashtra Ophthalmic Society, and it's on the occasion of World Diabetes Day. Now, as we all know that India has beaten China to become the diabetic capital of the world. And as of what the statistics stand today is we have over 200 million diabetics, which amounts to around 20 crore diabetic patients. Now, 30% or more of these patients will develop some form of diabetic retinopathy if screened in time and seen in time. And perhaps 10% or more of these patients will develop vision-threatening diabetic retinopathy. So in this regard, it's very important for not just retinologists, but also the general ophthalmologists to be aware of what is new, what are the ways of screening, the protocols, the imaging modalities that we have at our disposal today, how artificial intelligence might change things in the coming years, and of course, the treatment strategies and referral protocols. So we planned a wonderful seminar. We planned a wonderful seminar today, and we have a galaxy of eminent panelists, which are the greats of retinology in Maharashtra and the country. We've got a fantastic panel of subject experts who will be giving talks on various topics. So with this background, I would like to hand over the stage to Dr. Shirish Thorat, who's the president of the Maharashtra Ophthalmic Society, to welcome all of you.
Thank you, Dr. Piyush. Good evening, all. And it's my pleasure and honor to welcome you all to today's webinar on a special day of World Diabetes Day. Thank you, Dr. Piyush, who is a dynamic scientific committee chairman of MOS, for bringing together all esteemed national and international faculties to share their insights on different diabetic-related topics. I thank each and every one of you for being here. Special thanks to all of the speakers, experts for their time. Friends, I would like to take this opportunity to request all the MOS members to involve actively in our diabetic awareness day programs throughout the month. Thank you once again, and let's make this webinar a grand one, a productive and insightful session. Thank you. Thank you. Back to Piyush.
So, Dr. Dharmesh, is Dr. Nati joining us?
Yeah, he's joining in 1 minute.
So in the meantime, let me quickly introduce some of our expert panelists. Of course, none of them require any introduction. We all know them as some of the best teachers, the senior most and the most knowledgeable practitioners that we have in our country today. We begin with Dr. Pramod Bende. Sir is, of course, the director of the Vitreoretinal Services of Sankar Nethralaya. He's taught most of the people present over here and continues to teach us till today. So thank you for being here, sir. We've got Dr. Udyan Dikshit, sir, who's one of the senior most retinal surgeons, retina specialist in Maharashtra, and he's based out of the city of Pune. He also practices in England, apart from Maharashtra. Got Dr. Bhushan Khare, sir, who is one of the gentle giants of retinology, like I like to say, and again an alumni of Sankar Nethralaya, as is our next panel, Dr. Nitin Prabhu sir, again from Pune, and one of the senior most retinal surgeons. Dr. Vatsal Parekh sir will be joining us. He's one of the senior most and most trusted retinal surgeons in Mumbai. We've got Dr. Girish Gadre, who takes care of practically the entire south of Maharashtra in terms of sheer volumes that he's looking at. We've got Dr. Rishikesh Naigaonkar, sir, who's the chief at Ganpati Nethralaya in Jalna, one of the premier institutes in our state. And we've got Dr. Ashwin Bhafna, who is a very senior retinal surgeon practicing in Mumbai. So with this, we shall probably begin our webinar. Just one request is to perhaps stick to your timings of 8 minutes so that we can have 3 minutes of discussion. And Professor Natarajan has just joined us. He's just landed in Rome. And thank you, sir, for taking the baton. And you'll start off with the webinar.
Thank you.
So Dr. Dharmesh, Dr. Dharmeshkar is our moderator for today, along with Dr. Manish Bapai. So Dr. Dharmesh is practicing in Mumbai. Again, a very accomplished surgeon himself and a prominent speaker internationally as well as nationally. So, Dr. Dharmesh, can you introduce sir, and we can begin with our webinar.
Thank you, Piyush, for the kind introduction of everyone. Padma Shri Professor Natarajan sir, my teacher, guru, mentor, doesn't need any introduction. He's well-known worldwide. So I'll just invite sir and request sir to start the presentation. So
Thank you, Dharmesh. Hi, Anna. How are you? So I'm going to come to Singapore on 21st, and tomorrow I'll be in Budapest. So thank you all. Hi, Pramod and Udayan and all friends here, Girish. So I'll just share my screen. So you can tell me to stop at 7.5 minutes and I'll do that. So can you see my screen?
Yes, sir.
Okay.
Yes, sir.
Anyway, thanks, Piyush. And yesterday, the Shankaranath alumni, I could not log in because of the FRC's exams. Thanks to Piyush and the Maharashtra Ophthalmic for talking. And this is I've decided this as my next dream project for me, which I started from 2017 in All India Ophthalmic Society. I call it Jod Se Jod Jalao. So diabetes is now considered the epidemic of 21st century. And diabetic retinopathy is a major cause of blindness in the working middle-aged adult population and fifth cause of blindness globally. And this is the IDF Atlas 2021. And I think even in the, this is again 2017. And I think recently in the Lancet, Dr. Mohan Vishwanathan team, his daughter, Dr. Anjita, had published saying that there are 100 million diabetics in India, and 58%, that means 58 million, 5.8 crore people do not know they have diabetes. It's a sad state of affairs. And diabetes, every diabetic will be affected with some problem because it's a small disease, small vessel disease. It's incurable, and eye symptoms are too late, and prevention is better than cure. So this is why, even though I'm an aggressive vitreoretinal surgeon, I recommend primary checkup, and prevention is better than cure, which we learned in preventive and social medicine. And I used to laugh at that. Now I feel we should prevent, even though in spite of doing all that, I think we'll keep seeing the proliferated diabetic retinopathy. So this was the coin termed by Dr. Baba Rajendra, the past president. Diabetes invariably affects both eyes. Test your eyes soon. And this was the initiative of IMA and AOS at that time, and along with the Dr. N.S.G. Raju. And this is a public interest the president of All India Ophthalmic Society. I would like to thank the International Advertising Agency for starting this competition for making a campaign on preventing diabetic blindness. And I also like to thank Allergan for the generous support to make this public initiative movie to create awareness on diabetic retinopathy and how to prevent diabetic blindness. So this, I think everybody should put it in their clinic. Are you a diabetic? You may go blind. What? Pardon, voice is not coming? But there's no voice. It's just a visual, just to say that why screening is important. The words will come now in the slide form.
The world will forgive you, but will you forgive yourself? Diabetic blindness is preventable. If you're diabetic, you need a retina checkup to prevent vision loss.
And this is what we wanted to convey. And we did it in the Andrea Gasse, and we did everywhere. I mean, you can see the Maharashtra Ophthalmic going for the screening. So effective screening program for diabetic retinopathy is important. Maharashtra Ophthalmic did it in the last year at leadership of Dr. Santosh Agarwal, determine who needs to refer to an ophthalmologist for close follow-up and possible treatment, and rest of the people can have a periodic checkup. Every citizen deserves an eye checkup. And these are the initiatives which we have done in our foundation, where we do all the slums of Mumbai and some parts of the Dharavi, Mulund, Daisar, everywhere. And then we also have a van. So this is the eye screening on wheels where we use the motorbike to do the screening. You can see this is a school dropout, and he is actually carrying this forest camera, which we are doing it from 2014 to do the diabetic retinopathy screening. The idea is we do not need a technician, we don't need a ophthalmologist, we don't need optometrist. They can go into any part of the city or village and do this screening. And this guy can assemble and reassemble this forest camera, and it can go in the bumpy road so that the optics are not spoiled. We have a Zeiss camera in the mobile van, which you have to keep it under in a box with some suspensions and all, so that it doesn't get spoiled. So the idea is do the vision check, and he can do the no need for an optometrist, and he can do wonderful pictures better than a retina fellow or myself. And this is with Forest, and Forest also has come out with the AI. And this we did it in Sholapur, and we created a Guinness record. So the idea is to create pre-camp awareness, assembly of diabetics, capturing of images and uploading, and use either the diagnosis done by remotely by ophthalmologist or AI using the net, or offline AI like us, or image graders. So we want this has to be integrated with the National Health Mission, the central government, state government, and there are so many things available in the market. Funders on phone camera. And this is just, I don't have any financial interest. I use the Remedio camera a lot, apart from the Forest and Zeiss. And this is a comparison between funders on phone and Zeiss. And the company called Meteos, which is now bought over by Remedio, have made a software which is offline. That's the reason I recommend it, because we don't need internet, we don't need electricity. We can charge the mobile, that is iPhone. And now I got recently another camera from Argentina. It's called Philcom, where from Brazil, we can attach an Android camera, and and there's a small cushion-like thing which will cover the eye, so that it creates a dark environment, and you can take a fundus photograph. The difference is this is an offline AI which will say who need to be referred to diabetic to the specialist and who need not be referred. And so we did this as the first of its kind, and this is the again, we don't need a technician. So you can see anybody can be trained. So I call this as the ABCD. Anybody can be used for screening for diabetic retinopathy, and you can select the image, put it on the media software, which will say that the photograph is taken 99% well, and then you can use the photograph, apply it on a software. You can see the blue, which will detect the retinopathy, and will say refer to a retina specialist or not. And then so the sensitivity and specificity of AI in detecting referable DR was 100%. And we also work with the endocrinologist for doing a diabetic retinopathy awareness and association with multiple comorbidities. We have published a thing called Diamond Study. And the main thing is early detection and treatment after screening can reduce the prevalence of diabetic retinopathy, even in the remotest area in the country, reduction in the economic burden among poor and illiterate, and opportunity for a non-skilled worker, like anybody can be trained. A person who's saying tea or putting drops, he can train and give one skill, and that skill is taking retinal photograph, and it will improve overall health of the population. And my desire is in Dharavi we get funds from patients or well-to-do people, do the blood test ourselves. We do a HbA1c, postprandial and fasting, and from the age of 35 every year. And in case it's 35, 36, 37 is normal, and the age of 38 is diagnosed diabetes, we recommend to take a fundus photograph and go back, and once a year he can do that. And when he get the earliest changes, he can go to the treatment. So this is the AI is the way forward, and we have to merge virtually and biologically, and that closing the merge between the technology and us. One day it will happen, even though in the robot movie it was a fiction, but you don't have to. You don't have to be an AI comes. There is a role for everybody to have, including the doctors. And we have this IDX, which is FDA approved, which is very expensive compared to what we are going to use. And this is IDX one Wisconsin has, Forest has got. And then this is the first one which we have made, is the first offline AI for screening of diabetic retinopathy. We are continually using in the Municipal Corporation of Greater Mumbai, and now it's called Kamala Sundaram Foundation. And that was the pilot study which published in JAMA, which was the most viewed article in 2019. And what happens if poor images, the reliability rule out non-diabetic retinopathy cases drops to 81.9, but the referable still remains 100% reliable. And that's what is the study. And we are reliability of AI for screening population for diabetic retinopathy in the need of ophthalmic checkup by an eye doctor is 100%. So if we see 100 patients, maybe only 90 can go home and 5 to 10 can go to the doctor, so that we can use the extra care time. So there's a more job opportunity, skill development, refer the patient early. The eye doctor can concentrate on treatment and timely medical surgical intervention to prevent complete loss of vision. And and Google is also trying. So the key benefits of using offline AI, the social and economic dimension, early detection, and then you get more images continuously. It improves outcome, relatively low cost and highly scalable process with quick response time. And then we need the Kumbh Mela is coming. This we did in 2019 with UP State Society. And then this Dr. Shobha Shivaprasad has done in Kerala. Similar thing I proposed to Maharashtra and the BMC dispensaries. So and we also made a foundation to make India blind free, which is a long-term goal. And that's a future plan I have to extend this work done by Shobha Shivaprasad in Kerala to Maharashtra first. And then, so they found 1 in 3 patients with diabetes detected with diabetic retinopathy, and 8.3 was referred. 99% of the patients were unaware they can develop diabetic retinopathy. This is in Kannur. A similar thing we want to do in BMC. We are doing some, but we want to do in the entire 199 Apla Davakhana, which we want to do. So this is what I want to conclude my talk by saying we can train many people and use them for screening so that retina surgeons can do the treatment. So I quote Swami Vivekananda and conclude my talk. Thank you, Piyush.
Thank you. Thank you very much, sir, for the excellent presentation.
Thank you, sir.
And I'll request Piyush to introduce Dr. Hannah, and then both talk will be on the AI. So we'll take the question together.
I think that's a great idea. So it's a fantastic honor and a privilege to say a few words, because if I go on, I don't think we'll have any time remaining for the rest of the talks about Professor Tan. So Dr. Anna Tan, first of all, thank you for being here with us and sharing your work with Selena. So Professor Anna Tan is a clinical associate professor and a senior consultant ophthalmologist at the Singapore National Eye Center in Singapore. And she's also clinical associate professor at the Duke University of National University, Singapore. She's an avid researcher. She has a number of peer-reviewed articles, over 100 editorials, multiple book chapters. She's constantly representing SNEC at local international conferences. She's a key opinion leader for majority of the companies like Zeiss, Roche, Nidec. She has multiple awards to her credit, including, I think, the Catalyst Award, the Publish Award. She is currently also the director of the Global Eye Health Low Vision Service Center, and she's clinical director of the Ocular Imaging and the Retinal Center as well. So with this background, I would welcome Professor Anna C.S. Tan to deliver her talk on artificial intelligence for diabetic retinopathy screening.
Hi. Thank you, Piyush, for the great introduction. Can you hear me? Is it good?
We can hear you, Professor.
Okay, great. And thank you, Prof. Natarajan, for your great talk just now. I'm also going to continue in this theme. I think the WHO has already given us a roadmap in terms of people-centered care innovations. And you can see our digital innovations just highlight some: mobile health, wearables, telemedicine, and telehealth. These all actually are digital solutions that we can actually use to be able to help our patients. So you can see another way to look at it really is to look at the traditional patient journey. In the traditional patient journey, you map the journey of how they enter and what their current standard of care is. And then you look at the limitations. And then after that, you can look at the digital solutions that are available. And this is relevant to many other settings. So, usually I think one of the things we always talk about now is innovative eye care delivery models. And you can see there's a pyramid of the eye care that we deliver all the way from community, primary, secondary to tertiary. And in every one of these areas, we can look at siting the right care at the right site to maximize the efficacy of eye care delivery. In some settings, some solutions are possible. In other settings, other solutions are possible. But we definitely know that the traditional method of screening, where a diabetic patient comes in, goes through a clinical examination with an ophthalmologist and receives their diagnosis of diabetic retinopathy or not is very, very inefficient. And these are the gaps because there's so much diabetes. I mean, like India, the numbers are just astounding. Everything in India is like mega sized to me. Every time I hear about that, I feel Singapore is like so small. So, you know, and it's an aging population. And we know that there's a lot of disability due to diabetes, both in the eyes and everything else. And we know that there's a limited number of ophthalmologists, unevenly distributed ophthalmologists, and lack of access to care, and also limitations of infrastructure. So this high inefficiency model deprives people from receiving timely treatment and is not cost effective. So really a solution would be, implementation of AI. And you can see that I think Prof. Natarajan went through quite lots of different systems. I will tell you a little bit about our Singapore system and how we use it. First, I want to just also break down sort of components of a comprehensive, digital care model for diabetic retinopathy screening. So first, of course, it requires color fundus photo imaging. And you can see this can be done by multiple people. We need the right camera, we need the right infrastructure, we need the right grading, and the grading can also be done by a lot of people. And then also we need the right reporting and referral process and the scaling up. And you can see we can harness digital technology and task shift, which is a very effective way to help us improve efficacy of this system. So you look at also this recent paper that was published by the London School of Tropical Medicine people, and they really identify a few areas where we should look at when we want to implement diabetic retinopathy screening programs in our specific context. So I'll just go through a few. Diagnostic accuracy is important, and you can see the sensitivities and specificities were really quite high with most of the algorithms that they looked at. The remedial and some of the other ones were mentioned here. But these algorithms, take it with a pinch of salt. When you look at the sensitivity and specificity, you must always ask yourself, what was the gold standard used? Was it the standard of care? Was it clinical grading? Was it color fundus grading by humans? Were the cutoffs used? And are these validated in all populations? Because we know different algorithms, if you use a population, for example, a racially different population, it may not be validated for another population. And what is the accuracy that we actually need? A lot of them are very accurate and highly sensitive already, but in our local context, what is the accuracy we actually need? Implementation outcomes are very important. You need to look at the current patient journey, you look at the current diabetic retinopathy screening, who pays for it, and the manpower and the resources needed, and how it's sustainable. And these all are things that will help you implement a successful AI pilot if you want to do one. And a pilot study is really important because it helps us first do some external validation of the algorithm. It also helps us compare cost effectiveness of the previous standard model of care versus the new model of care, which is the AI model of care. And these should be very well designed to advocate for sustainable change to help governments understand the benefit of putting in this new technology. Here, I just put it in a diagram, some different scenarios of a country A where the ophthalmologist does a screening, a country B where fundus photos are taken but grading is done by ophthalmologists, and country type C where fundus photos are taken and grading is done by a non-ophthalmologist, which is obviously the most ideal. So to reach up to the green regions, we may need different interventions along the way, and the interventions along the way, I've put it in the circles. These are some of the interventions that SNEC and in our context, we can help train and provide. And you can see from manpower, fundus, cameras, digital infrastructure, and also training of graders. These are all something Singapore, we are very happy to look in collaborations with places that want it to see how we can help plug the gaps. In Singapore, you can see we have a national screening program. It's easy for us because we only have like 6 million people, and our area is very small. You can see the camera on the top right is not the camera we use here. We use standing cameras, but this is a very useful portable camera that I've been taking to outreach places out of Singapore. In Singapore, we use a standing camera, but it's a national program, and all the normal images are graded first by the AI that you can see. So the graders only look at 10% of the normal images and all the abnormal referable images for a double screen. So there's always a human involved, and we do not depend on the AI alone. And this is important for medical legal reasons, and it needs to be tailored for the local needs, context, infrastructure, and governing policies. So you can see that These are the validated cameras we have. The Remedial is actually one of them. But somehow the Remedial, when it's handheld and it's sometimes fundus with the fundus iPhone camera, it is more variable. And so sometimes this sitting camera where you put your face there is a more recommended one. We also have WHO approved courses. We are WHO CC, and we have a framework for the primary graders and secondary graders. And we just talked about these benefits of, applications of DR screening with fundus photos. I think apart from the efficacy and the cost effectiveness, we also can really get access to undersourced areas. And the data collection of these populations, which are not usually studied, is really important. In the future, we can even look at not just screening diabetics or diabetic retinopathy, but we can look at screening normal populations for diabetes without the need of taking blood. And we can even use fundus photos for that purpose, and that will transform screening kind of cares. Other considerations, of course, you need to look at regulatory approvals, technical support costs, and infrastructure. There are challenges, that we have identified, and you can see overcoming challenges are really healthcare system specific. There is AI bias, quality control, language barrier, and of course, cost is the biggest thing. And sometimes, sitting all together and brainstorming what's the best way to go about it is sometimes a very good way to see how we can all, make advances to the future. And I think the future is bright, and I think there's a lot, the costs are dramatically coming down with more and more, competitors coming to the market, and democratization of AI technology will really help us be more accessible to everyone in our populations. So thank you very much for inviting me. And I think I just am 5 seconds after time.
Thank you so much, Professor Anna. It was a wonderful, wonderful talk, and especially because you stayed up and spoke to us despite being 1.5 hours ahead. So with that, I would also we would like to invite comments from our expert panel, especially Dr. Pramod Bhende sir, who I believe Shankara Nethralaya also uses a lot of AI for diabetic screening.
Pramod sir. Maybe we can take.
So you're muted, sir.
Yeah, can you hear me now?
Yes, sir.
I think something with when I connect headphone, I think I can't. I guess mic gets goes off. I mean, congratulations, and both the talks are wonderful. And yes, we use particularly Rajiv does much more AI than any one of us. Rajiv Raman, basically, he is specialized in a lot of publication he has. And yes, I mean, both talk, nothing much to add. Dr. Natarajan, yes, epidemiology, we have issues, and our population itself is a major chunk. And whatever we do is not enough, actually. We need more and more resources. And more, basically, I think its commitment is more important, what I would put there. And AI is its future to go, I think. And that's definitely going to, basically what we are looking at is to cutting the costs. Yes, initial investment will be more. But once the cameras are in place, and that is done, and non-ophthalmologists, technicians going around, basically a lot of areas we cannot reach, areas where you can have a diabetologist, or general physicians, we can have a cameras there and make it as a routine. And of course, AI will help us to analyze these images. Of course, somebody will be there, and ophthalmologists or graders will be there. I think that's the way to go in future, so that will help us to actually reach the far village areas, remote areas population, and going to help us. I think that's the way to go. Treatment part is totally different, but once you cut down sizable amount and when you have selected number of patients, we'll obviously have we have a chance to work around to get those arrange for a treatment for these patients. But you catch at early stage and filter out major chunk. I think that's the best way to go.
Absolutely, sir, because we see that most of the patients that are, of course, urban areas have a higher prevalence as compared to rural areas because the facilities of examination and screening are higher, and the requirement in rural areas, especially in India and China, is comparatively much higher as compared to urban areas. So, absolutely, sir. Anybody else would like to make any comment from the expert panel?
I was surprised to read an article which was published on 30th of October by Dr. Shreya Shah from Stanford, giving the percentage of patients who really undergo examination by AI. To quote her figures, it was, I can't even believe it, it's 0.09%. Is it that low, doctor? Is there any reason because that it's not still reaching? The resistance was not from patients, it was from the ophthalmologists. Because they're not trained, because they don't want to adopt quickly, or it's difficult to reach the masses. I'm not talking about resistance from patients. Are ophthalmologists heartily welcoming AI, or they are not?
Yeah, so it's a bit of a complicated issue, I think, because I think, in places where the ophthalmologist is remunerated for the clinical examinations that they do, then the adoption of AI and trying to do this without a financial incentive, they can't charge for it. For example, if you can't get remuneration or you can't get your government to pay for it, then it's not something that they will adopt. I definitely have spoken in the Philippines to quite a few, and they have actually a lot of ophthalmologists in Philippines, but they're all in Manila, and the outskirts can benefit from it, and they are willing to use in the outskirts, but definitely within the cities, if your financial incentive comes from seeing patients, then it's not something you may want to adopt. So I think that is one of the barriers. I think the other barriers is really about knowledge, about just people don't really know how it works. People are afraid it makes mistakes. So there's always this thing, is like, but it's not 100% perfect. But then actually human graders are not 100% perfect also. So there's a big discussion in URetina with the English, the NHS people and things like that, to just say, we just have to get on with it, because human graders are not perfect too. The AI can help, but maybe the extra layer of a human checker is probably the way to go, where you get a good medical legal side, as well as you can still make use of the AI.
This could be just the initial resistance, like for anything which is new.
Yeah.
We'll get over.
Thank you, Dr. Dixit. Thank you, Professor Tan, and thank you, Dr. Natarajan, Professor Natarajan. We'll move on to the next talk, and Dr. Dharmesh, can you invite the next speaker, please?
Sure. So Dr. Abhishek Desai is here. I invite him for the webinar, and you can kindly unmute and share your screen.
Dr. Abhishek Desai, can you?
Yes, sir. I'm trying to share.
So Dr. Abhishek Desai is a young and dynamic surgeon. He's based out of Jalna at Ganpati Nethralaya.
Are my slides visible?
Yes, you'll just have to go into full screen mode.
Yes.
And he'll be speaking to us about OCT and diabetic macular edema.
Yes. Thank you, Dharmesh sir, for the introduction, and Dr. Piyush for this opportunity. So let us see in brief about the OCT and diabetic macular edema. As discussed earlier, it is the global epidemic of the modern era, and diabetic macular edema is the most common cause of the moderate visual loss in diabetic retinopathy. So making the OCT as a gold standard and the excellent predictor and monitoring the treatment response in such cases. So basically, the normal OCT is look like this. And in diabetic cases, the earliest change that is visible on OCT is the microaneurysm, which can be seen as a vertically oval structure, mainly located in the inner layers of the retina. Now, the traditionally based on drcr.net, the OCT is used to classify diabetic macular edema into the center involved and the non-center involved by seeing the thickness in the central subfield area, that is the central one on the ETDRS grid. And morphologically, it is classified into a spongy macular edema or the cystoid or the one with the neurosensory detachment. Also, the one important area to look for on OCT in diabetic cases is the vitreomacular interface area, where we can see the taut posterior hyaloid with incomplete PVD or the complete PVD, Also, we can identify early the tractional component in such cases by seeing the TRD or the vitreomacular traction syndrome, which needs a surgical intervention early so that we would have a good outcome. So coming to the another set of parameters that are useful in cases of diabetic macular edema based on OCT are the central subfield thickness, which is nothing but the average thickness measured in the central 1 mm area of the ETDRS grid. But it has the inter-device variation because different machines use a different normative database and different segmentation, so making it a less reliable because of its low sensitivity and specificity, but it can give us fair idea about the response to the treatment. But we can see it has anatomical and functional discordance. That means many times the edema disappears on LCT, but that similarly it is not reflected in the visual acuity and vice versa. That is, sometimes you have high edema but with the good vision. So similarly, this is the latest paper which highlights this, that the CST should not be considered as a surrogate for the changes in the visual acuity. Same is the case with the macular volume, which has a strong correlation with the central subfield thickness but poor with the visual acuity. Now, another set of important parameters or the qualitative parameters are the biomarkers, which are quite unique to the many of these cases, like drill. Drill is nothing but the disorganization of retinal inner layers, where we are unable to distinguish between the different boundaries between the different layers on the inner retina, especially the ganglion cell, IPL complex, INL, and OPL layer. It should be assessed in the central 1000 microns area of the OCT, and it is the robust markers that signifies the macular ischemia, which is validated by many longitudinal and cross-sectional studies. It signifies the damage to the neurotransmission pathway, which involves bipolar, amacrine, and horizontal cells. So basically, if drill is present, then we can explain to the patient that you are going to have a little less outcome or poor visual outcome. So is it really helpful for the selection of the therapeutic cases in such cases? So this was the study which concluded that there is a greater reduction in the extent of drill was observed with the DEX implant as opposed to the anti-VEGFs, but with no significant difference in the visual acuity. Now, the next important biomarker is the hyperreflective retinal foci. Many times it is confused with the hard exudate. Let us see how to differentiate between the two. The hyperreflective retinal foci, basically these are tiny hyperreflective dots which are mainly seen in the inner layers of the retina or inside the retinal cyst, and which has the reflectivity similar to that of the nerve fiber layer. However, the hard exudates are much bigger, larger, and they leave a trail of shadow behind, and they are usually seen in the outer layers. So in some of these examples, we can see in upper picture, the hyperreflective dots are seen in tiny into the retinal cyst, whereas the hard exudates are seen as a much bigger, larger lesions in the outer retina of the OCT scan. So in chronic cases, these hyperreflective dots are arranged in the form of circle within the cyst, which is called the pearl necklace sign, and it represents the poor outcome in such cases. However, being inflammatory in origin, these dots respond well to the DEX implant in comparison to the anti-VEGF injections. The next set of biomarkers are the outer retinal biomarkers, that is disrupted interdigitation zone, ellipsoid zone, and external limiting membrane. Out of the all four hyperreflective bands in the outer retina, these layers constitute the inner three except the outer RPE layer. Normally, they are seen as a smooth, uniform, hyperreflective line in the outer retina. And in diabetes, sometimes this continuity gets lost. We call it as a disrupted, and this represents the damage to the most important structures for vision, that is photoreceptors and the RPE. The length of the damage correlates negatively with the visual acuity, indicating a poor prognosis in such cases, which is highlighted and concluded by this paper, which is published recently. But if we intervene early with anti-VEGF or DEX implant, it can be reversible, and those patients are associated with the better visual care. There are many more other biomarkers, but because of the time constraint, I am limiting myself to the retinal biomarkers which we have discussed recently. Now, as we have seen in earlier two talks, there is a lot of buzz these days about the use of AI tools in the understanding of the diabetic macular edema also. So there are many deep learning and machine-based algorithms which can highlight the area of discordance or the area of interest where there is abnormality in the form of heat map. And in future, based on the data published or the meta-analysis, these AI tools can predict which therapeutic agent is going to benefit most in this case, and how is the outcome or prognosis, and what is the injection interval is going to be in this case. So this is the area which is going to be need to be explored in coming days. So to summarize, OCT has revolutionized overall understanding the pathology and disease in diabetic macular edema, and these days we cannot imagine practicing and treating the macular edema without the use of the OCT. Thank you everyone. Thank you for patient hearing.
Yeah. Thank you, Dr. Abhishek, for
Thank you, Dr. Abhishek. So you've just dissected it out so beautifully and made it very simple to understand. Thank you for the lovely talk. Dr. Dharmesh, would you like to call Dr. Jay?
Yeah.
What we'll do is, we'll just finish off the three talks, the remaining two talks, which speak about imaging, and then we'll have a discussion on it.
Sure. So that's a great idea. And now I invite Dr. Jai Seth from Shantilal Sanghvi. He's a young dynamic guy from Mumbai, and he will talk on FFN, OCT, and diabetic retinopathy. So Jai.
Yeah. Hi. Good evening, Dharmesh. Thanks for the kind introduction, and thanks, Piyush, for inviting me to deliver this talk on a very interesting talk of a role of fundus fluorescein angiography and OCT angiography in patients with diabetic retinopathy. So I'll quickly move on to my talk, and I'll be giving a more of practical talk about how this imaging is actually helping us, and we'll go through few interesting case-based scenarios also. So just to give a background, I mean, DR is a major cause of vision loss on a global level, and as Piyush correctly pointed out, we are actually going through a kind of an epidemic of diabetes in our country. So the retinal microvascular damage can lead to a variety of retinal complications ranging from microaneurysms, hemorrhages, exudations, and to neovascularization also. So early detection and monitoring of these pathologies is very critical so that we can give timely management for all these patients. So first we'll go to the fundus fluorescein angiography. So what are the clinical applications where we consider doing an FFA for the patients? The first and the foremost is, when we have patients with a macular edema. In these patients, microaneurysms that are seen on fundus fluorescein angiography are much more than what we see clinically. So this is a patient with bilateral moderate NPDR changes and with a lot of microaneurysms in the, especially in the left eye, as we can see. So this is the early FFA. And in the mid FFA, we can see very beautiful pinpoint hyperfluorescence that are classically seen in patients having microaneurysms. And in the late stages, they keep on leaking, and there's a lot of hyperfluorescence that can be seen in the macular area. So correlating this is very important, because especially for patients whom we are considering a focal laser photocoagulation in these eyes. The next is, of course, to look at the blood circulation throughout the retina. So it helps in early detection of ischemias, any neovascularizations, and also very, very important in patients in which the media are hazy. So like this is one of the patients who had like a frank proliferative diabetic retinopathy with a subhyaloid hemorrhage in the left eye. And when we look at the right eye images, we can say whether is it a kind of a severe NPDR changes, and not sure whether the patient had PDR in this eyes. So this patient, we do a fluorescein angiography. And in the early phase itself, we can see this diffuse area of hyperfluorescence located in temporal part of the macula. And in the late phases, it gives those classical leakages. So there is an early PDR that is happening even in the other eye. And these kinds of patients, they definitely need a laser photocoagulation. So multiple NVs were also, of course, detected in other quadrants also. And in the left eye, of course, it was a frank PDR, and those neovascularizations could also be seen in the other eye also. And this is the OCT of the patient showing presence of a CME also in both the eyes. Then there are patients like asteroid high losses, which is very common in patients with diabetes. So in the right eye, if we see there's an area of a fibrovascular proliferation in this location. So, in right eye, we can conclusively see that the patient has got a proliferative diabetic retinopathy. But if we look at the left eye with a dense edge, we may not be able to exactly pinpoint, say, whether the patient has an NPDR change or PDR. So when we do a fluorescein angiography in each patient, we can see this neovascularization that is located just inferior to the disc. And in the late images, there's a frank leakage that happens from this area. So, in these kinds of patients also, FA is very, very useful. But it has got its own limitations that it is an invasive procedure. So we cannot keep on repeating it at multiple visits. It has got its own adverse events ranging from mild nausea, vomiting to even a lot of anaphylactic reactions also. And of course, it is nephrotoxic. So we have to be very careful in patients who have simultaneous diabetic nephropathy also. So herein comes the role of OCT angiography, which is a very high resolution imaging technique which helps us to evaluate both retinal and choroidal circulations. And it helps us to do a very precise intravascular flow. And of course, one limitation that would be we cannot see leakages that is classically seen in fundus fluorescein angiography. So what are the applications of OCT angiography? So OCT, if we look on the image on the left side, the top image shows the FFA image, and microaneurysms can be beautifully seen on the FA. Now, correspondingly, even the OCT angiography, we can see the microaneurysms also. So we can consider doing an OCT angiography also in few patients of where we consider focal laser photocoagulation. The image on the right hand side where we see is beautiful areas of capillary non-perfusion can be detected in all these lower images on the OCT angiography. And the corresponding fluorescein angiography, of course, confirms the CNP areas as well as the neovascularization in this area. So these are the two very common indications where we can consider doing an OCT angiography. And the other thing would be to detection of neovascularization. So if we look at this patient with a frank PDR with a kind of a combined occlusion also. So there's a beautiful neovascularization of the disc that is seen on the OCT angiography in these eyes. So if we want to avoid doing a fluorescein angiography, OCT is very useful in such kinds of patients. Additionally, it also helps us to do a quantitative evaluation as well as follow-up in these patients, and very early detection of macular ischemia is possible, and how the FAZ is enlarging can also be quantified on OCT angiography. And not only that, even quantification of peripheral capillary non-perfusion, whether how is it progressing in pre and post anti-VEGF treatment, can also be evaluated on this. So OCT angiography definitely has certain advantages, including it being a non-invasive investigation. We can do a quantitative analysis for these patients, and we can repeat it at multiple visits, and as well as it does not have any kind of systemic adverse events. But at the same time, it has got its own limitation, like it is an expensive technology. It does not detect leakage. So in those patients, it may be very difficult. Like if you want to differentiate between a diabetic macular edema and a pseudophakic macular edema, it may be very difficult for us to do only an OCT angiography. Additionally, it has got a limited field of view. We are going to have a next talk on Widefield fluorescein angiography where this can be explored more. And as well as that, it has got its own limitations, including artifacts and other segmentation errors. So I'll quickly go through a few very interesting case scenarios that we can discuss and how it practically helps doing both these imaging. So this is the first case of a 54-year-old gentleman. He was a family physician and a diabetic since 15 years with a creat of 4.2. He came for a routine diabetic retinopathy screening and had a vision of 20/20 in the right eye and 20/30 in the left eye. So this is the fundus photo of the patient. A lot of cotton wool spots and hemorrhages. So clinically, if we see, clinically we'll grade the patient as having severe NPDR changes with presence of diabetic macular edema in both the eyes. And these kinds of patients typically we'll start on anti-VEGF therapy, and especially with creatinine of 4.2, we'll avoid doing a fluorescein angiography. But for this patient, I did a Widefield OCT angiography. And if we look at the right eye, so there were very early neovascularizations can be seen as pointed out by these yellow circles. And even in the left eye, very early neovascularization was seen. So our diagnosis actually changes from a severe NPDR to a proliferative diabetic retinopathy. And the line of management actually changes from not only anti-VEGF therapy, but also doing a PRP for this patient. Now, a second case is another 50-year-old gentleman who was diabetic since 12 years, and his visual acuity in the right eye was 20/60 and left eye it was 20/40. So if we look at the fundus photo of the left eye, not much changes, just mild NPDR changes can be seen with few areas of microorganisms in and around. Now, if we look at the OCT, there's minimal amount of retinal thickening that is there and very mild fluid, but it does not tell us exactly why is the patient's vision 20/40. So when I do a fluorescein angiography for the patient, a lot more microorganisms can be seen as compared to what was seen on clinical evaluation. But the FAZ was, it cannot be conclusively said, whether there's any damage to the FAZ. But when I do an OCT angiography, very beautifully, we can see the macular ischemia. And so this can easily correlate with 20/40 vision. And just because of presence of retinal thickening, there may be no benefit of going an anti-VEGF therapy in this patient, and we can just explain the guarded visual prognosis for this patient. The third case is another 69-year-old lady who was diabetic since 15 years and left eye vision of 20/60 and right eye of 20/30. And she had got presence of moderate NPDR changes with diabetic macular edema in both the eyes. So this is the OCT photo. And on the left eye, we see presence of a serious macular detachment with intraretinal fluid. And right eye, very non-center involving DME with mild cystoid spaces in the temporal part. So I advise a fluorescein angiography in the the left eye fluorescein confirmed presence of moderate NPDR changes. Now, in the right eye, if we see, there was present of few microorganisms more in the temporal part, and correspondingly in that location, there were the cystoid changes. So these are the two specific microorganisms that can be leaking and giving rise to this fluid that can be seen in the temporal quadrant. So this patient was definitely advised only focal laser in the right eye, whereas because there was center involving DME in the left eye, the patient was advised anti-VEGF therapy. And after a month, his visual acuity improved in both eyes to 20/20, and left eye showed complete resolution of edema. And in the right eye also, because of the angiography, we were able to detect the microaneurysms, and there was resolution of the large cystoid space that was there. And just one very important caveat is that OCT angiography may not be very sensitive in detecting microorganisms. So around 30% of these lesions can be missed on OCTA as compared to a fluorescein angiography. And just one final case. This was a 62-year-old
Can we skip this one?
Yeah. Okay.
You've overshot by 3 minutes.
Oh, all right. So sorry, Piyush. So, I mean, this was just a simultaneous CSR that was present in a patient with a diabetic retinopathy. So if you can see, there was a CSR leak that was there. So it's very important to keep in mind that there could be other pathologies also that can help be detected by fluorescein angiography as well as on OCT angiography. Okay. So thank you very much for your patient hearing and sorry for overshooting.
No problem, Jay. It was absolutely worth it. A lovely collection of cases as well as dissecting it out so simple to understand by even most of the general ophthalmologists. Thank you very much. And I now would like to ask Dr. Manish Papai to introduce our next speaker, Dr. Sharad Bhumaj, sir.
Good evening, everybody. Our next speaker is Dr. Sharad Bhumaj, sir. He's a senior vitreoretinal surgeon from Sangli, having extensive experience in medical and surgical management of all the vitreoretinal diseases, not just diabetic related. He will be dealing with the topic of Widefield imaging and fluorescein angiography in diabetic retinopathy. Over to you, Dr. Bhumaj, sir.
So what we will be doing is we'll take questions after Dr. Bhumaj's talk on imaging that we just discussed.
Dr. Bhumaj, could you please unmute yourself, sir, and share your screen?
I'm trying to share, but it's not getting shared. It's got shared now. It started.
Yes.
Able to see?
Visible.
We can see your desktop. Yes. Yeah. No, we can see it presentation.
Thank you. Yeah, good evening, everyone, and my respects to all our seniors and my colleagues, and special thanks to the scientific committee of MOS, including Dr. Piyush Bansal. So I'll be talking a few moments about this ultra-wide field photography and angiography in diabetic retinopathy and its importance. So first of all, what is ultra-wide field? So ability to image the retina outside the anterior edge of the vortex vein ampulla, that is the far peripheral fundus, constitutes the ultra-wide field imaging. Anything inside this will be constituted as a wide field imaging. So as we use the 7 standard fields for recording the fundus photographs and the angiography as per the TDRS criteria, you can see that a lot of area of the fundus remains undocumented by this. And that's where is the utility of the current generation of ultra-wide field angiography devices. So Optos, which gives us the almost 200 degree of single shot view, is the gold standard for ultra-wide field imaging for retinal diseases. However, there are also limitations with the Optos, and you need to even sometimes do the collaging of this even with the Opto system. So this is showing you the steered images. So the other options are Zeiss Claris, which also gives you beautiful images. So you have to take 2 photographs, one from the nasal and from the temporal fundus. We have Nidec Mirante, then you have got IDON, and there can be many other devices. And for fluorescein, you have got the Spectralis, which gives you a wide field, and with steering, it can reach the ultra wide field territory. So basically, there are various technologies and other things, and each one have got their own strengths. So basically, what are the advantages of using the ultra wide field imaging in diabetic retinopathy? So basically, it is the ease of capture compared to the traditional fundus camera, which can be taxing for us to capture and then create a montage. So ease of capture, that is the most significant advantage. Second is it is very fast, so very comfortable for the patients, require just few seconds per eye. It gives a panoramic view. So you can see right from the disc to the peripheral fundus, so which gives you a very nice complete view of the entire fundus. It can be imaged in undilated or poorly dilating pupils. That is also a very good advantage. So sometimes in the OPD patients, some people are not ready to get dilated. And if they don't turn up for follow-up, we may be missing some very severe disease of diabetic retinopathy. So it's very important that we do an undilated ultra-wide field fundus photography of this patient to get a good view of what exactly is happening in the diabetic retinopathy for that particular patient. Again, extremely useful for patient counseling, because a picture can tell 1,000 words, and it is very useful for patient counseling. Apart from this, telemedicine, very useful. Then an excellent documentation tool, because when you document this, because of the ease of documentation, at each visit, you know what's happening to the patient. You have got a library of images of what has happened in the past and other things. So it's an excellent documentation tool. Last but not the least, learning tool both for the doctors and a teaching tool for the teaching institutes. There are a few limitations, obviously, that this technology is a bit costly, definitely. It is not portable. You can't carry out a camp or do the outreach activities with such kind of devices. There can be some artifacts which can prevent you to get good photographs. And especially if the media is very hazy, then you can have suboptimal results. But in spite of that, there is a good role of ultra wide field imaging, and we shall discuss. So basically, it provides you a more accurate grading of the retinopathy severity. So you can see this is a fluorescent angiogram of early NPDR, and you know that this is definitely a early NPDR. This is another patient, again a moderate NPDR, and it shows you minimal changes, and you know that it is consistent with the clinical picture. But many times the clinical picture may be masking the underlying disease can be quite severe. So in this particular patient, you might have diagnosed as a moderate NPDR, but actually the patient is having multiple edemas and early non-perfusion areas. So this is a more severe kind of disease, which is important for us to have more frequent follow-ups and regular follow-ups. This is another patient. You can see that you can have the exact documentation of the entire fundus. You can see the non-perfusion areas, the neovascularization areas, the edemas, all the things. So we can get beautiful anatomy of the entire fundus in one shot. Now, another patient where there are neovascularization tufts, but the extent of severity, it is documented by this ultra-wide field fluorescein angiography. You can see there is almost global ischemia, and you know the implications and the urgency of treatment, and that can be explained to the patient. Even in cases of uh, frank diabetic retinopathy, proliferative diabetic retinopathy, the extent of the non-perfusion, this is a global ischemia, you can see, and it has got a different implications for our visual prognosis and follow-up. Many times, because we are doing ultra-wide field imaging, it is imaging the peripheral fundus. So are there any advantages in the diabetic retinopathy, which is predominantly a posterior disease? In 10 to 15% of the patients, you can have predominantly peripheral lesions. You can see in this patient, this has got an extensive non-perfusion of the entire temporal half of the retina, temporal peripheral retina. And these are some of the patients where who have come with neovascular glaucoma after surgical interventions, including vitrectomies for nucleus drop or something like that. You have not diagnosed the extent of retinopathy. And after cataract surgery, after vitrectomy, these patients directly end up into neovascular glaucoma because you do not know the extent of severity of the diabetic retinopathy at that given point of time. So there are a few studies which have looked at the peripheral findings, importance of peripheral findings in the diabetic retinopathy patients, and they call it as a predominantly peripheral lesions. So we define these predominantly peripheral lesions as when more than 50% of the lesions are located outside the standard ETDRS 7 fields. We call it as a predominantly peripheral diabetic retinopathy. So this is an example where you have got predominantly peripheral diabetic retinopathy, especially where you have got associated non-perfusion. They can have very aggressive deterioration of the diabetic retinopathies. So they have got more likelihood of diabetic retinopathy progression, especially when associated with peripheral non-perfusion on fluorescein angiography. These patients are at higher risk of post-vitrectomy bleeds. Sometimes you do not know why the patients are bleeding in spite of this thing. So these have got a predominantly peripheral disease where their peripheral vasculature is leaky, and they are. This is an example of ultra-wide field fluorescein angiography. The upper row shows you patients who do not bleed, which have got a stable fundus, whereas the lower part, these three images show you these patients have got leaky vessels. So they have got a tendency to bleed. So on ultra-wide field fluorescein angiography, you can document why this patient is bleeding in the post-operative period and predict the patients who have got a higher risk of post-operative bleeds. The other advantage is to have a simultaneous view of all phases of angiogram in the entire fundus. So you can see that unlike the traditional photography where you have to take shift the images from one sector to other, at one shot you will have the all phases of the angiogram, which can give you some additional details. So you're not missing that phase of angiogram for that particular sector. Now, as we said, asteroid hyalosis in diabetic retinopathy. These ultra-wide field imaging devices, though they can also do fluorescein angiography, they also can do wide field autofluorescence. So if you use white light, then the light scatters. So with the single wavelength light, like in autofluorescence, you can examine the fundus and have a good picture in spite of having asteroid hyalosis because you are using a single wavelength. So this is an example where the autofluorescence imaging is used to guide the adequacy of the PRP laser. So you can see the lasered areas are hypoautofluorescent and the freshly lasered areas are hyperautofluorescent, and the isofluorescent areas are unlasered. So it will give you a guide to whether you have completed the PRP properly in such patients. Now, because we can see the peripheral ischemia and the peripheral lesions, there was a concept of having a targeted retinal photoaggregation. So what is that? That is that you give PRP predominantly to the non-perfused areas of the fundus on fluorescein angiography. And one advantage definitely, as by this Peter Pan study, is that significant reduction of post-PRP central retinal edema and keeps the side effects of the laser to a minimum. The drawback of this is that because diabetic retinopathy is not a static disease, you will have to monitor these patients over time to see if they worsen and add additional laser. So more follow-up will be required. Other application which was proposed was that the peripheral ischemia could be driving the diabetic macular edema. But over the period of time, two studies, prospective controlled trials, both for ranibizumab and for aflibercept, have demonstrated that there is no additional advantage of controlling the diabetic maculopathy, and there is no treatment difference in the treatment burden for the anti-VEGF treatment for the diabetic maculopathy. So targeted retinal photocoagulation may not be a very useful technique for controlling the diabetic macular edema. So in summary, ultra-wide field imaging has got very important applications in diabetic retinopathy management, which are underutilized, because I see that even people who have got access to this technology, they do not use it properly, or the inadequate utilization occurs even in the institutes which have got these ultra-wide field devices access. So the technology is very good and the applications are good, but because it is very costly, the important thing is that it should be more affordable to increase the accessibility to all the ophthalmologists. Thank you.
Thank you, Dr. Bomat, sir. That was a wonderful talk. I think the point to carry from this is there is areas of there are areas of non-perfusion which are there in far anterior retina, which are often missed, and they need to be treated to achieve long-term outcomes. We'll take expert comments on these three talks regarding investigations. Can I have comment from Dr. Rishikesh Nagaonkar about his approach to investigating diabetic patient, as to a patient with clinically visible diabetic retinopathy? What is his preference for investigating the patient? Would he just do imaging, OCT, or FFA as well?
So the choice for me would be angio OCT and OCT for all the patients who are coming to us for the first time. For all the patients would undergo these investigations, these two at least, and subsequent investigations with fundus photography and OCT scans may not do angio OCT for all the cases. We of course do not have ultra wide field angio here, so I don't have much of experience as far as that is concerned. For cases, there are certain cases which do not respond, or where we feel that there is some diagnostic dilemma, or where we feel that we need to do maybe focal laser. So in such cases, then FFA still holds an edge over the newer modalities of investigation. So overall, this would be my approach for the cases coming to the OPD.
Thank you, sir. Can I ask Dr. Bhushan Khare as to how do you use your OCT to guide your treatment and following up your treatment for diabetic macular edema? Any parameters, any biomarkers that you would look for when you're deciding upon the injection and follow-up and progression of progression of the treatment?
Yeah, one thing was OCT helped us change our definition of diabetic edema from what was a CSME to a center involving macular edema. So we define every patient in which center involvement is there. It also gave a modality in which we could sequentially check every month as a follow-up of the patient at the same location, how the retina is responded. And it was the only modality which was objectively giving us information of the vitreoretinal interface, which dictated surgical treatment in these patients. So if you ask me an assessment, every patient, of course, in addition to the best corrected visual acuity, it is the central retinal thickness which dictates most of our decisions. If, however, vision doesn't correlate with what we see on the OCT, then a fluorescein angiogram becomes mandatory to evaluate, or a OCTA to rule out macular ischemia. It's also maybe one of the best tools in which we can correlate what we see and explain it directly to a patient before and after treatment. So it is one of the best educative tools and explaining prognosis to a patient. macular ischemia is so nicely demonstrated on a OCTA that we can easily explain to a patient why the visual change is not there or why a poor prognosis is going to be the reason why we are not going to treat that patient aggressively. Also, in a special case like pregnancy or renal impairment where angiography may not be possible, OCT becomes the only tool in which we can monitor these patients.
Thank you. Thank you very much, sir. And we can ask Vatsal Parikh, sir, is using about the Widefield modalities in diabetics, sir. Your inputs.
So besides, say, my place, the routine would be all patients, since we have the Silverstone machine which captures OCT, ultrawide field, FFA, the routine would be that patient will have a fundus photo after basic clinical examination and OCT. If patient is willing and is fit, we would do angiography also as a basic parameter, Besides what everyone told, what I feel is important for ultra-wide field angiography, where I found it useful, is number one, patient of vitreous hemorrhage. Clinically, you may see vitreous hemorrhage and just little detail of retina. Now, at the age group of 60, 65, patient is diabetic. You don't know whether it is acute vitreous detachment or posterior vitreous detachment or diabetic retinopathy. Ultra-wide field FFA definitely help in some of these patients because though the blood is there, the technology itself will show you CNP areas and NVE. So that is one biggest advantage what I feel. Number two, all diabetics who undergo vitrectomy for PDR, I normally do ultra-wide field FFA to see the macular perfusion. So otherwise, I think whatever everyone has said, I would agree. And finally, what I was thinking and what I've been doing FFA for recurrent vitreous hemorrhage, I think that has been nicely told by Sharad, that somebody in 2013 has done studies, because I feel that many of these patients, if we do ultra-wide field FFA, we'll know more about it.
I think Dr. Nitin Prabhudesai also has access to ultra-wide field FFA. So can I please ask, sir, how has your treatment treatment for diabetic retinopathy changed after you have started using ultra-wide field imaging system?
No, unfortunately, I don't have the FFA mode of that device. I have only the ultra-wide field color photography available and autofluorescence imaging. But basically, even with the ultra-wide field color photograph, if you go into the green red free mode, many a times in earlier new vessels, fine new vessels in the periphery can be picked up. So it definitely helps us in deciding whether this patient needs PRP or needs close follow-up, or we can avoid doing laser for him. So it's a good mode. But I think most important is, as mentioned earlier, you should consider, especially in so-called mild to moderate NPDRs, we should consider FFA at an early stage, because many times the early phase is the one where we can treat properly. And later on, if you tell the patient that he's fine and you can come up 6 months, he sometimes lands up after a year with gross PDR. So early doing FFA early and using the wide field, even the color mode is helpful in detecting the peripheral lesions.
Dharmesh, just one point, if you allow me to add.
Yes, sir.
The best advantage of this SLO technology, ultra-wide field photography, is that you can zoom the image whenever you want and see many lesions which you would have missed clinically,
So I have this question for Dr. Sharad Bomaj, and I think we'll wrap up with this question and go to next talk. Dr. Bomaj, classically we have been taught to do laser till mid periphery while doing PRP. After you have started using the ultra-wide field FFA, do you laser the patient right up to aura? Do you prefer to do that vis-a-vis classic PRP, or there is no change in that?
You'll have to unmute yourself.
So please unmute yourself, sir.
Yeah, sorry. So at our place, we do the as peripheral as possible with the PRP 165 lens. So that takes us to the far periphery area. And those only when you have got persistence of neovascularization, we do scleral indentation and LIO. And intraoperatively, obviously, we go right up till the aura. So in an OPD setting, we go as peripheral as possible. And those who don't respond, then we do a scleral indentation LIO treatment.
Okay. Thank you, sir. I think with that, we should go to next set of talks on management treatment modalities. And we have Dr. Amit Nene, who will be talking about role of intravitreal injections in patients with diabetic retinopathy. Dr. Nene, as we all know, is a very great, very good surgeon who posts a lot of his videos. He works in Isha Netralaya. So over to Dr. Amit.
Thank you, Manish sir, for the kind introduction. At the foremost, I would like to thank MOS and Dr. Piyush sir for giving me this opportunity. So the topic which was I was given today was intravitreal injections for diabetic retinopathy. So I think this is the most important slide. I have no financial interest in any of the injections which I will be describing. So as the earlier speakers have already mentioned, OCT has become our superhero. So I think everyone, even the comprehensive cataract surgeon, must have a OCT at his place to diagnose these kind of macular edemas. And because of these, the procedures of injections are also rising day by day. They are becoming more than the cataract surgeries. So a lot of injections are available in the market. This is an off-label injection. No one talks about it, but most of them use it. So this is Avastin by Roche. Even government schemes like MJPJY advocate the use of Avastin. Then there are these injections like Acentrix, Eylea, and the newer injections like Paganex and Vabysmo. And not to forget these biosimilars like Ranezurel, Razumab, Osiva, Rani-Eyes, and many other biosimilars in the pipeline. So these are all anti-VEGF injections, and to complement them, we have a steroid injection in the form of Ozurdex. So these injections we started from 2004, and over a period of time, many of them have been given a FDA approval to be used in diabetic macular edemas or even in vascular occlusions. But as far as I know, everyone uses all these injections in all kind of indications. So this is how these molecules look like. I won't go into details of these molecules, but I will make this little bit clinical talk. So there are a few basic questions: when to inject, which to inject, how much to inject, when to switch, and the role of anti-VEGFs along with cataract surgeries in diabetic macular edema. So whenever there is a clinically significant macular edema, there is no doubt that we inject anti-VEGF in such patients. If there is a OCT thickness of more than 300 or 400 microns, then that is a threshold at which we inject. However, recently, if we see few patients who have a visual impairment or a decline in visual acuity, it is a critical factor for initiating therapy, even if a clinically significant edema is not present or a center involving edema is not present. Foveal involvement with edema typically warrants intervention, even if the central retinal thickness is not excessively high. Even with few cystic spaces at the fovea, we usually inject in such patients. Now, which injection to give? It depends mostly on various factors, with cost being the most important factor. So even if bevacizumab is an off-label injection, however, there are trials like BOLT and DRCR.net trials which have shown that it is as effective as other biosimilars or Acentrix in treating diabetic macular edemas. Ranibizumab is a FDA-approved drug for treating DME. Vista DME trial has shown the role of aflibercept in treating DME, and they have used it as a first-line drug. The advantage is it has a longer duration, and it might be of help in some patients who prefer not to take these injections on a monthly basis. Now, the recent injections which we have come, the Kestrel and the Kite study for brolucizumab, and the Tenaya and the Lucien trial for for faricimab, they have shown that they are non-inferior to aflibercept, and they recommend it as a first-line therapy for DME cases. However, we should be very careful in monitoring the ocular inflammation, which is seen with both these injections and have been reported by many of our colleagues also. So whenever a patient presents to us with these kind of pictures like drill, or many chronic cystoid spaces, or the entire RP and the photoreceptor layer is not seen clearly. So this is our drug of choice. So Ozurdex becomes our boss. And the MEAD and the Geneva trial have shown that it works really very well in the refractory DME cases. It should not be used as a first line and should be used only when these anti-VEGF injections are not effective or suitable. Many of our colleagues are also using Kenacort in place of Ozurdex, which is also off-label. But according to my experience, it works really well in chronic DME cases, similar to Ozurdex. There is a chance of raised intraocular pressure, but it can be very well controlled with topical AGMs. So this chart is to the best of my knowledge. I think every of our colleague gets different rates by the same companies. So Avastin, usually for each patient, if in a vial, we can give at least 25 injections. So the cost comes down to 1,000 or even less than that. And we can give it for around 5,000 to 6,000 for each patient. And the rest of the injections are as shown in the table. So this is very basic how to inject. So we should always remember that we should take one step at a time. A few of us try to inject in both the eyes on the same day, but it is always better that we inject in one eye, wait for 3-4 days, and then inject in the other eye. Because if end off happens, then it is really troublesome. So these injections are usually given under topical anesthesia. My preference is to always put povidone iodine on the conjunctival surface at least 2 times with a gap of 5 minutes in between. I use a sterile marker to mark the site for the injection, usually 3.5 to 4 millimeters for the limbus in phakic and 3 to 3.5 millimeters for pseudophakic and aphakic patients. Inferotemporal quadrant is the most preferred site, although any quadrant can be used for injection. It is necessary to cross-check the eye of the patient, name of the patient. It is necessary to even see the patient once before the injection, whether the edema has resolved or not, because these patients usually go to many other places. They check out the rates and then they come back to us, and that gives around a month or two. So the delay is a month or two. So it is always better to see these patients before the injection again. We should check for any air bubbles in the syringe before the injection, and a 30 gauge needle is sufficient enough to give these injections. It is usually given perpendicular to the sclera with a firm entry, and a sterile cotton bud is placed over the injected area for 10 seconds. Role of pre and post antibiotic drops is debatable, but in our institute, we usually give topical antibiotics in post-injection patients. So this is just a small video on how we inject Ozurdex. So earlier we used to inject Ozurdex under subconj anesthesia, but now we have started doing it under topical anesthesia only. So we are marking the site for injection. So once we remove the cap of the Ozurdex, the entry should be little bit tangential and then vertically directed towards the retina. So with the help of a bud, I am just stabilizing the eye, and we have to just click it, and you see that the entire implant is inside the eye. So once you get out, you need to check whether the entire injection has come out or not. So the next question is how much to inject. So there are basically 2 approaches, a structured approach and a treat and extend approach. Initially, the treatment includes 3 monthly injections and then a maintenance therapy, which may be around 8 to 10 weeks based upon the response. As I said before, OCT is very critical in determining the need for further injections. Treat and extend is a flexible protocol, and it depends upon the clinical response on how the patient responds to the initial injection. So basically, it should be tailor-made for each and every patient, how much injections and when to inject. So the other thing about these injections is when to switch. So first of all, it is very necessary for us to admit that we need to switch it and not just continue on giving these injections. So if there is a lack of response to initial therapy, that is if the patient has received 3 or 6 months of anti-VEGF treatments in which he receives around 3 to 4 injections of any of those anti-VEGF and the macular edema still persists, then it is necessary that we switch. If there is frequent recurrence of macular edema, or if there is a financial burden on the patient, so that is also one of the important criteria to switch. So we can switch from a ranibizumab or a bevacizumab to aflibercept or even Paganax or Vabysmo because they have a longer life and the repeated need for injections is a little bit decreased, not to that great extent. It is imperative that we add a steroid like Ozurdex in refractory or chronic DMEs. And nowadays, I have started giving combination therapies with anti-VEGF along with steroids for patients with persistent or recurrent edemas, and it works really well. The next thing is if a patient, usually these patients have cataract also and have present with some kind of diabetic macular edema. So these macular edemas with minimal cystic spaces are usually not caught by the naked eye, but on OCT we are able to see these cystic spaces. So what to do then? So usually for such patients, it is imperative that preoperatively the macula should be completely dry, and they are usually given 3 to 4 weeks before the surgery. And once that edema goes off, we usually plan the cataract surgery. But if the macular edema persists or recurs after the cataract surgery, then another set of injections would be usually required after a month or so. So giving anti-VEGFs with cataract surgery is also a matter of discussion. But at our institute, we usually prefer giving them together, the cataract surgery along with the anti-VEGF injection. Just a slide on the newer intravitreal injections, Abicipar, Pegol, Razupro, Tafib, and RGX-317. So it is a gene therapy which has been developed, which delivers an VEGF inhibitor into the retina. So I was not able to get much details, but these are the three drugs which are there in the pipeline. The another interesting concept, novel concept, is of the port drug.
We need to go faster, Amit. They've already overshot.
Is the port drug delivery system. So it is a permanent refillable ocular implant, but again, cost is a constraint. The side effects, as we all know, there are many ocular side effects and systemic side effects also, but they are relatively rare. There are some contraindications, the important ones being chronic kidney disease, pregnancy is an absolute contraindication, any recent history of thromboembolic events, and active herpetic eye disease. Thank you.
Thank you, Amit. We'll come back to questions and comments later, but it was a very interesting talk, like you said, and extremely well broken down the various aspects. So, Dr. Dharmesh, please call the next speaker.
Yeah, so now we'll invite Dr. Manoj Sasavde sir. He is leading senior retina surgeon in Maharashtra and he's from the Aurangabad. So Sasavde sir will talk on role of lasers. So kindly share your screen.
Am I? Oh, sorry. Okay. Am I audible?
Yes,
we can hear you, sir, but we can't see the slides.
Why it is not sleep?
That's it, sir. That's the one.
Yeah, it is visible on the screen.
Yes, sir. Can you go to full screen mode, please?
Okay, 1 second. Now is it visible?
Yes, sir.
Okay. Good evening, Dr. Piyush sir, Manish, and Dharmesh for giving me the opportunity to speak on the first webinar in your tenure. I will be speaking on the lasers in diabetic retinopathy. We know that the laser is a light amplification by stimulated emission of the radiation. The laser's properties are various properties: monochromatism, coherence, polarized, collimated, and high energy. And the effect on the tissues are either because of the thermal effect, photochemical, or ionizing effect. And for the retina, we know that there are various pigments like melanin, hemoglobin, and xanthophylls, which absorb the light energy and converts into a photocoagulation. Well, there are new modalities like micropulse or sub-threshold lasers also in useful in the diabetic maculopathy. We know that, as already Dr. Bhomas sir has discussed about the Widefield angiography, the role of laser is to convert the ischemic retina to unexcited retina. That is, because of that, there will be no oxygen demand and no VEGF secretion. And if there is no VEGF secretions, we know that there won't be no neovascularization of the elsewhere as well as the disc, and this reduces the vascular permeability also in cases of DME. So indications of lasers in diabetic retinopathy is either it is in the diabetic maculopathy, proliferative diabetic retinopathies, as well as neovascular glaucoma, severe NPDR cases, and diffuse diabetic maculopathy, of where you can use the micropulse laser. And there are various types of machines available in the market. They can be indigenous as well as imported one, and this can be of single spot lasers as well as multi-spot laser, and deliveries can be in the for the diabetic retinopathy, either it is slit lamp delivery, indirect laser delivery, and intraoperatively you can use the endo laser delivery. But whatever the laser machines you are selecting, you should be very sure that it should be of high reputation and with the precise or precision, where the spot size and the energy should be delivered properly. And when you are starting the laser, you should know the screen in front of you, where you can change the parameters like the power, what is the exposure time, what is the interval between, and what type of mode, whether you are using single spot, repeat, painting, continuous mode, or multi-spot mode. In multi-spot, you can have a multiple spots at a time, as well as you can have a macula sparing designs also, where you can save the macula. And while doing as a technique, if you are doing on the slit lamp is the preferred method of laser delivery in cases of diabetic retinopathy as well as maculopathy also. Where the prerequisite is that you should take the written consent preferably. There should be a darkroom trained ophthalmologist and helper, and who should know the machine in detail. Height adjustable stools and tables are important, because of the many a times the patients cannot sit for a longer time, as well as they are on the wheelchair. Suitable laser machine and delivery systems and lasers should be available. But for the diabetic retinopathy, two lenses are very important. That is HR centralis as well as for the maculopathy, and for the peripheral lasers, you should have a suprachoroid 165 or 160 Manchester PRP lens. Then there should be good control of the sugar before you do the laser, and people should be fully dilated. And the role of the lasers in a diabetic maculopathy, as already discussed, the diabetic maculopathy can be of focal, diffuse, ischemic, and mixed type of. In focal maculopathy, there is a definite role of the laser. We know that it is a time tested, and years together we are doing. In a focal maculopathy, we know that there is a succinate hard exudates around an microaneurysm, and you have to select that microaneurysm, which can be seen on the photography, slit lamp biomicroscopy, as well as on the angiography. And that microaneurysms can be directly shoot with the light burn. And the burn should be of the 100 micron size, and duration of the interval should be 100 to 50 to 100 milliseconds. Then here also you can see that there are multiple succinate exudates. Here the laser works very well, and you have to see the every succinate, and at the center of the succinate put a light gray burn of 100 micron. Then another indication is the lasers in a diffuse maculopathy. Diffuse maculopathy is a little bit tricky and usually associated with the systemic derangement in the patient, and where it is reluctant to for all types of modalities of the treatment. Laser is one of that. You have to take the help of the injections of the anti-VEGF as well as the angiographies and OCTs to monitor these cases, where you can take the help also of the micropulse lasers in for doing the grid lasers in, and that is also nowadays we are doing the modified grid laser, where the C-shape the grid laser is done, where the confluent burns are given of the light intensity, but you have to prevent the burns in the papilomacular bundle as well as very close to the fovea, at least 300 to 250 to 300 microns away from the center of the fovea. Then comes the role of micropulse or subthreshold laser, where the basic idea is that you prevent the direct damage to the RP, you stimulate the RP, and which is in the inertia stage will drain the fluid, as well as it will secrete the cytokines, and so edema is reduced. Then next indication is in the cases of the proliferative diabetic retinopathies, where there are various types of NVs, NVDs, as well as the tractional retinal detachment. Here you can see that there are various neovascularization of the disc and sclerosed vessels, where we will see that the PRP, how it has been done. It is done in sittings, 1 sitting, 2 sittings, or 3 sittings. But nowadays with multi-spot lasers, and you can do in 2 sittings or in 1 sittings also. But how to start? For the beginners, you should do it in the supranasal or infranasal quadrant first. 1 disc away nasally from the disc in the nasal side. And second, you can do in the infratemporal and temporal side, and superiotemporal taken last. And for the beginners, one more thing is that he should line the macula 2 disc diameter away from the fovea, so that inadvertently he will not hit the macula. The another thing is that how much is the intensity of the burn. It should be mild to moderate intense, and later on it becomes a heavy. And heavy burn should be avoided. Second most important thing is that the spacing between the 2 burns should be one burn apart. Later on they coalesce and produce a large scar. And in 1 sitting, one should do the at least 600 to 1500 burns in 1 sitting. This is one of the things where you can see exactly how much of the ischemic area is there and how much area is to be treated. That is, all this is non-capillary, non-perfusion areas which should be taken care in the PRP. Here you can see that after giving the anti-VEGF, we have done one first scatter multi-spot laser, and it should cover the almost whole retina in the first sitting, and subsequent sittings you can cover the remaining areas or leftover areas. The most beauty of the laser is that it is a time-tested and a golden standard in the proliferative diabetic retinopathy. If you do the proper PRP, it's literally prevent the blindness over a long term. And you can see that everyone in sitting here will be seeing such types of patients coming over 15 years, 17 years after a good PRP, and they are having good vision.
Okay.
Full PRPs.
But time is already overshoot, sir.
Oh, okay, sir. These are the PRPs after this one. Then here you can do the PRPs, full PRPs. Laser is again used for the stabilization of the disease, like in TRDs, where the macula is attached. You can do the fill-in PRPs. Here also the leftover area, that is on the angiograph, you can see that the proliferation persists because of the someone has not taken the care of the full retina. In vitreous hemorrhage, you can do the PRP to the available retina, and in follow-up cases also you can see that there is a persistent neovascularization. Again, do before surgery also you can do the laser to reduce the vascularity. And in cases of the severe NPDR, or the patients who are not able to keep the follow-up, you can do the lasers 1 sitting or 2 sitting. And there are limitations of laser. Despite of full PRP in these cases, still there is a neovascularization because of deranged systemic control, and there is no role of lasers in a purely ischemic maculopathy. There is a role of lasers in a neovascular glaucoma, where you can do the tight laser PRP, and you can use one more laser modality, that is TSCPC in such cases. Post-op follow-up, usually you should do the analgesic and topical steroid and antibiotic combination. And those people who are doing the lasers, they should learn that it is a technique, and over a period of time you will master it. But it should be learned properly under the care of the master. Otherwise, you will do the wrong type of laser. See, this is the laser which is again inadvertently done. Very huge area, and large blood vessels have been destroyed. Or here you can see that the continuous laser has been given, which will completely damage the nerve fiber layer as well as the large blood vessels. So post-op care is already we have discussed. The complications can be infective keratitis, uveitis, exudative RDs if you have done the exudative choroidal detachment if you have done extensive lasers, and there is a loss of accommodation for some time. A worsening of the cystoid macular edema, ERM formations is one of the things. Night blindness and field of loss is also one of the things if you have done the heavy lasers. Retinal breaks formation at the heavy laser burns edges, and secondary seen at times can be seen at the ruptured Brooks membrane. Thank you very much.
Thank you very much, sir, for the amount of information that you have conveyed in such a short duration is incredible. But due to paucity of time, we'll move on to the next talk. May I invite Dr. Preetham Samant sir to please share his slides. Now, as we all know, Preetham Samant sir is one of the most loved and respected retina surgeons in Maharashtra and around the country. So, are you there?
I'm very much here, Piyush.
So nice to hear your voice. Welcome, sir. And I invite you to, sir, Manoj Sasode, sir, can you please stop screen sharing?
This is stopping.
So, first of all, many thanks to dear Piyush and MOS for having me here.
Thank you, sir, for accepting and being a part of this webinar. I mean, it's not just that you're limited to a teacher. We all admire you as a friend, philosopher, and guide. So may I request you to please share your screen.
One second,
Dr.
I'm just.
Preetham will be talking about PDR vitrectomy. It's a very important topic, as these are the patients who are at the most risk of developing permanent blindness because of vision-threatening diabetic retinopathy.
One second. Once I share my screen, I think I have to click on the desktop, right?
Yes, sir. On the lower hand, the lower border of the Zoom panel, there is a button which is colored different. It's greenish in color with an arrow pointing upwards.
I know. Once I do that,
then you have to you can click any of the windows that open up.
No, so it's not. It's telling me that allow Zoom Workplace to share your screen.
Yeah. Rahul, can you please guide?
It's giving me a saying open system settings.
Yeah. Click on that, sir.
Okay, now.
Yeah, allow your screen to zoom, sir, because you are using Mac, sir.
Yes.
So please on the Mac security preferences होता है ना, तो उसमें आपको allow करना होता है zoom को screen share के लिए.
Yeah, but it's not showing Zoom
Hey,
there.
click on open system preferences.
Yes, and Zoom. Okay.
Yeah.
Zoom is unselected. You have to select the Zoom.
Yeah.
Yes, sir.
So it is selected now, but what after that?
Desktop.
I'm clicking on it.
Rahul, will you be able to help sir out by a phone call? And we can perhaps take the next.
Yeah, I think so. Let's just go ahead with the next one. I'll figure it out with.
Sir, please give me the contact number, sir.
That's all right. We'll do that. Okay. May I invite Dr. Suhas Sonavne, sir? An alumni of Sankar Nethralaya and practicing in Due. To speak to us, Dr. Suhas Sonavne, sir, are you there?
Yes, very much.
Thank you for sharing your screen. She'll be speaking to us about phaco, a very important topic, phaco in patients with diabetic retinopathy.
So, dear friend, this is a little odd topic for the retina person. How most of the points are covered by Dr. Sasode and Dr. Amit Nene. Actually, the people suffering from diabetes, they have got a higher incidence of development of cataract. The risk is almost 2 to 4 times higher than in non-diabetic patient. So, patients suffering from diabetes are higher risk of developing of cataract, though in diabetic population, the indication for the cataract surgery may be same as for non-diabetic, but it is also include the need of retinal examination to perform the laser treatment. Unfortunately, the diabetic cataracts has been associated with higher post-operative complication rates than non-diabetic. And we should also remember that cataract surgery may make diabetic retinopathy worse. So macular edema before the surgery is the most common condition which limit the post-operative visual recovery. Thus, the pre-operative laser treatment and anti-VEGF treatment is is advisable before you perform the cataract surgery. And photocoagulation for the pre-proliferative and proliferative diabetic retinopathy is also advisable due to increased risk of progression of retinopathy or iris neovascularization. So timing of the cataract surgery. Recent trend is to go for early cataract surgery in diabetic, which definitely improve the visual outcome. The visual outcome are likely to be worse in patient in whom the surgery is delayed for a long time when it is not possible to identify or adequately treat the diabetic retinopathy or diabetic macular edema before the cataract surgery. The preoperative and intraoperative and postoperative challenges are factors are very paramount importance in the management of the diabetic cataract. Cataract surgery, when performed in diabetic patient, may lead to relatively rapid progression of diabetic retinopathy, precipitating vitreous hemorrhage and induced iris neovascularization, and ultimately may lead to loss of vision. So, particularly the early recognition and the treatment of diabetic retinopathy or maculopathy before cataract surgery influence the final visual outcome and plays major role in preoperative decision making. So, preoperative consideration before surgery, my patient must have a good glycemic control, and there should not be any evidence of ocular and periocular infection. And you should do a thorough ophthalmic examination to rule out presence of diabetic retinopathy. Patient with pre-existing untreated PDR, proliferative diabetic retinopathy, are more likely to progress and develop vitreous hemorrhage and retinal complications rapidly after cataract surgery. Therefore, photoretinal pan-retinal photocoagulation is recommended preoperatively. When cataract prevents preoperative PRP photocoagulation, then it could be administered as immediately following the cataract procedure, at the time of cataract procedure, at the end of the procedure, or it can be performed within a week after cataract surgery with indirect ophthalmoscopic laser. DME should be adequately treated before surgery, as pre-existing DME can be aggravated post-operatively, resulting reduced visual outcome. Again, in diabetic, considering the preoperative challenges, diabetic, the cornea, there are certain peculiar corneal problems in diabetic patient. There will be a high incidence of dry eye and defective epithelial healing in diabetic patient. Also, there is a risk of endothelial damage. Diabetic patient present lower endothelial cell density compared to non-diabetic individual of the same age group, and also cataract surgery in diabetic patient result greater endothelial loss compared to non-diabetic. Preoperative challenges, like the risk of definitely the diabetic patients are high risk of having post-op infection like endophthalmitis. And also there are so many pupillary problems like small pupil, people refuse to dilate with drops. This is because of sympathetic autonomic neuropathy, and this sympathetic denervation is directly related to duration of disease and development of systemic autonomous neuropathy. In diabetic eyes previously treated with retinal laser, pupil dilate less as compared to eyes without laser. Small pupil makes cataract typically technically challenging, and you have to take a stepwise approach by using intracameral adrenaline, lidocaine, or iris expander. And also you have to take care, you should be very cautious while manual pupillary stretching, because sometimes you might, because of iris neovascularization, you can land up into a bleeding and hypema. Also, the cataract surgery may make diabetic retinopathy worse. When managing cataract of patient with diabetes, you should always remember that cataract surgery may make diabetic retinopathy worse. Those with severe non-proliferative and proliferative diabetic retinopathy have a high risk of progressive disease, and clinically significant macular edema present at the time of surgery is likely to progress, and also eye with previously treated clinically significant macular are also at increased risk of recurrence. The risk of progression is increased if operation is complicated by excessive manipulation, vitreous loss, and post-op inflammation. So, ideally, you should treat and stabilize the diabetic retinopathy. Ideally, when cataract does not prevent laser treatment, you should treat it and maintain the effective control of retinopathy and maculopathy for at least 3 months prior before the surgery with the help of laser photocoagulation or anti-VEGF. The severity of cataract sometimes prevent adequate examination and the treatment of retina in patients with diagnosed or suspected severe non-proliferative or proliferative diabetic retinopathy. In this case, you do pan-retinal photocoagulation either during the cataract procedure or immediate post-op period. So you have to do an aggressive treatment of neovascular glaucoma. You should take priority over the cataract surgery, because prolonged increase in intraocular pressure can damage the optic nerve. Cataract surgery may exacerbate neovascularization. Intravitreal anti-VEGF is the main short-term strategy for control of neovascular glaucoma. Anti-VEGF treatment result direct decrease in intravitreal anti-VEGF levels and causes regression of neovascularization. Anti-VEGF agents are administered usually before cataract surgery, or it can be administered during cataract surgery or at the end of procedure or after post-op period. Once the neovascularization iris regress, you can consider phacoemulsification with or without vitrectomy at the earliest to enable the post-op posterior segment clearance of the posterior segment pathology. Alternately, combining phaco with endoscopic diode laser cyclophotography is also option for this. So, effect of cataract on macular edema. Diabetic patient after cataract surgery may develop diabetic macular edema following even uneventful cataract surgery. The impact of cataract surgery on DME is eyes without any DME before cataract surgery will have sharp increase in the incidence after surgery, and it can be picked in first 3 to 6 month period. The risk of treatment or requiring DME increase sharply in the first year of cataract surgery. So Amit has mentioned about the role of steroids and anti-VEGF. I'm not going into much detail. So what are the intraoperative considerations in cataract surgery? In diabetics, gold standard treatment for cataract surgery is phacoemulsification and with the foldable in the bag oil. Phaco induces less postoperative breakdown of the blood aqueous barrier than ECC. It results better post-op visual acuity, less postoperative inflammation, and less need for YAG capsulotomy than ECC. And here certain points you need to remember that anterior capsular phimosis is very common in diabetic. Rexis size should be larger than normal but should be smaller in diameter to prevent anterior IOL displacement on PCO. Large diameter optics, that is 6 mm, should be preferred because it allows good diagnosis and treatment of peripheral retinal pathologies. Longer the duration, complicated cataract surgery associated with great risk of progression of retinopathy. In diabetic, there is high likelihood of poor pupillary dilatation as mentioned earlier. So you may need iris hoop or iris pupillary expander. Intraoperative hypema due to presence of previous IDs, preoperative intravitreal anti-VEGF may delay the bleeding from the iris neovascularization. Photic retinopathy is also very common.
Sir,
Hello.
can you summarize?
Yeah. Also, coming to the intraoperative consideration of IOL, you prefer a large diameter IOL. Also, the choice of IOL is hydrophobic acrylic oil in diabetic patient. Multifocal and EDOP accommodating IOL should be. They are questionable and doubtful and controversial. Better to avoid. Iris claw lenses also should be avoided in diabetic patient. Sometimes cataract surgery also get complicated with the cystoid macular edema also. Okay, thank you.
Yeah, thank you,
Thank
sir.
you, Dr. Swaz, sir. Dr. Preetham is ready. Can Dr. Preetham please take over? Preetham, please share your screen and start, please.
Yeah, Dr. Preetham.
Dr. Preetham, are you there?
Yeah, hi guys, I'm here.
Yeah, can you please
Shall I
share
start
your
sharing?
screen, Doctor? Yeah, please, please.
Okay. So once I click share, it's a Windows opening up and it's telling me open system settings. So
It's on now. It is allowing the Zoom to share the screen and. Just go to system preference and allow the Zoom to.
yeah, I did that. But now once I do share on that green arrow, it is still giving a open system settings, it is saying.
Can we take the next talk and?
You know what? I will just come
Or
from
you can mail it or send it to the.
No. Hema's Mac. I will log on from Hema's Mac. You take the next talk. I'll come last.
Sure. Then we'll have a talk by Dr. Rohit Modi. He's a young dynamic surgeon from Mumbai, and he will talk on the very different topic, that is systemic control and role of diet modification in diabetic retinopathy. So please, Rohit.
Hi, sir. Am I audible?
Yeah, you're audible. Your screen is very much visible.
So thank you, MOS, and especially my
Just a second.
friend.
So
Yeah.
anybody who's not speaking, can you please mute yourselves so that we can hear Dr. Rohit speaking?
Yeah. Shall I start?
Yeah, Rohit, you can go ahead, please.
So, no financial disclosure. I would like to thank the entire MOS scientific committee, especially my dear friend Dr. Piyush, for this wonderful opportunity. Now, we all know through three major trials, BCCT, UKPDS, and ACCORD, that if a tight glycemic control is there, it can prevent or delay the progression of existing DI. And we do all tell our patients that you need a tight glycemic control. But can we go up beyond that? Are we just retinologists or eye specialists? Are we not physicians first and then a retinologist? And when we look at the global estimates, as Piyush also said at the beginning of this webinar, that we have way past China. We are contributing to the 1/4 global load. Probably a 1/5 or 1/6 of our whole population is diabetic. And we know that these diabetic patients are at severe risk of several comorbid and chronic conditions, such as myocardial infarction, stroke, nephropathy, neuropathy, dyslipidemia, apart from retinopathy. And larger number of patients with DME are overweight or obese, and they have associated morbidities such as hypertension and cardiovascular disease, as compared to patients who do not have any DME. And DME is one of the primary reasons a patient comes to us, because that's the most common cause of vision loss in a patient with diabetes. And if we see, 50% of these patients will eventually go on to die of cardiovascular disease. And the patients with DME have 2 to 3 times the risk of acute myocardial infarction and 200 times more risk of cerebrovascular accident. And these patients who have associated some cerebral lesions can have 20% more chances of stroke. And these are the numerous factors which contribute to the morbidity. Just 1% reduction in glycosylated hemoglobin can reduce the diabetes-related deaths by myocardial infarction by 21% and microvascular complications by 37%, which is a huge. 1 in 3 patients can get benefited in a big way. Now, we understand this track. We have seen this poster numerous times. Some of us have even put it on a clinic. And we do tell our patients to take meds, to reach healthy weight, add bit of physical activity. We do ask about the smoking history, and we ask them to control the comorbidities. But can we take another step ahead and tell them about some more important things? But first, let's understand what's type 2 diabetes. In type 2 diabetes, basically there is an increase in intramyocellular lipid, which blocks the action of insulin, and these gates are not able to allow glucose to come inside the muscle cells, which increases the blood sugar levels. So technically, if through diet and exercise we are able to reduce the amount of fat percentage in the body, increase the muscle mass through workout and the right diet, we can potentially reverse the disease partially or completely. And something similar was done 2 decades back. A low-fat, whole food, plant-based diet was compared with the standard American Diabetic Association diet, which was recommended that time. And the shocking results was there was a significantly more weight loss in the patients on plant-based group. Glycosylated hemoglobin got controlled even further. Cholesterol dropped, including the LDL cholesterol. And what these people were asked to do, avoid animal products such as non-vegetarian meat and dairy products, avoid processed food and ultra-processed food, which are fried products, oils, and high fatty foods. Favor low glycemic foods such as beans, which could be any lentils or legumes in our dietary lifestyle, and more of green leafy vegetables, which in fact increase the dietary fiber and complex carbohydrate intake, and also reduce the total saturated fat and cholesterol intake. And the amazing part was portion sizes, energy intake, and carbohydrate intake was unrestricted. Mind you, in a diabetic patient, you're not controlling the portion size, and still you are beating one of the most recommended American Diabetic Association diet on all parameters. And something similar was found in control of hypertension. The DASH approach, dietary approach to stop hypertension, found that a weight reduction and a diet which is high in fruits, vegetables, and legumes significantly reduce the blood pressure. Now, when we look at the DME risk factors, our blood pressure is getting controlled on a whole food plant-based diet. Glycosylate hemoglobin is controlled. Cholesterol is dropping. So most of the risk factors which are modifiable are getting controlled. So why not adopt that approach? And similarly, the same diet and lifestyle actually showed over a period of few years a reversal of chronic artery disease and an increase in myocardial perfusion by 3 times. And something similar has been done in India by Pramod Tripathi, who's based in Pune, but he is treating through his novel approach and he has published numerous papers. In fact, he has started a major prospective clinical trial to prove his efficacy of the treatment in reversal of diabetes. And this is exactly the same approach which was published 2 decades back by Bernard et al. So in systemic management, if we spend that 10 minutes extra apart from counseling about the treatment, about the importance of just shifting to a whole food diet. In fact, we can just tell that, stopping processed food, junk food, and packet food can have a huge impact on the patient's diet and weight control. A little bit of physical activity, something like 2.5 hours of cardio per week, 1 to 1.5 hours of sprint training, 8 hours of sleep, regular medication intake. And one more thing is, I'm sure all of you, especially seniors, have experienced a lot of these patients have stress, anxiety, and depression issues. Timely referral to a psychologist or a psychiatrist for counseling, or in some cases, adequate medication can help these patients calm down and take better control of their disease. These are some of the documentaries which shaped the way I have started my approach in clinic towards holistic healing. I would recommend them. These are free on YouTube. Thank you.
No, Rohit, Ashwin here. There is one important point which I would like to make here is that all of us as ophthalmologists also should be educated about what are the recent advances in diabetes. So one of the very, very significant advances that I have seen is development of what we call as continuous glucose monitoring devices, which over a period of time are going to become cheaper. These devices are just like patches which you can put on your body, and then you can monitor your blood glucose without pricking yourself from your phone. So each one of us should have some basic knowledge about this because we predominantly see diabetic patients. So if you educate your patient that there is a device which is available called as continuous glucose monitoring, which is available even on Amazon, right? So these patients will actually go and look into that, and glucose monitoring for them, becomes very, very, very easy. So moment they have something which food with a very high glycemic index, they see that spike in their sugars. So when they monitor that continuously on their phone without a prick, they actually understand that what they should eat, what they should not eat, and it goes a long way. I have seen my few patients, 10, 12 patients whom I've suggested and they've adopted to that, is that they become more cautious about what they are eating, when they are eating, and they are very happy with that. So continuous glucose monitoring is something, a device that I think we should also educate our patients about.
I completely agree with you. I have seen my patients getting better aware in fact, they themselves have stopped eating a lot of junk food when they realize the sugar spikes post usage of continuous glucose monitoring. Point well taken, sir. That's a very valid point.
What is your take on Ozempic? Have you heard about it?
Yeah. So Ozempic is a very good medication because it helps in weight control, also sugar control. But there are certain issues. Ozempic, once you start, you have to use it for life. If you're not having a high protein diet with enough of physical activity, the studies have shown that you lose more muscle mass than fat loss. And by chance, if you stop Ozempic in between, then the weight loss comes back with a vengeance. In fact, if you've lost, let's say, 4-5 pounds or 6 pounds, you may actually gain back 8 to 10 pounds if you stop Ozempic in between. So it's a lifelong therapy. So that is what we are supposed. Now, if you're putting a patient on a healthier lifestyle, a high protein diet, less of processed food, you're making him work out, so might as well as shift to a holistic approach and try that out, which is going to be done for life rather than shifting for an very expensive drug. Then again, one of the issues with Ozempic is the higher dose which is used, which is a once a weekly dose, is not tested for long term, and it has in some cases shown that the risk of thyroid cancer increases in some studies. So there is a lot of gray area which we still do not know about Ozempic. Yeah, it's a blockbuster drug. All celebs are using it, but it is damn expensive.
Yeah, I totally agree with you, and I take this point very well that you should have a high protein rich diet. In fact, if all of us here are listening, that there is one talk by I think Dr. Sabyasachi Sen Gupta on it. Very, very intricately explains that why you should take a high protein and a fat diet and omit glucose from this, because most of us diabetics actually suffer from what we call as insulin resistance. Rather than high blood sugar, it is the insulin resistance that causes the damage. So I have seen that change in myself after listening to Sabyasachi's talk on Facebook. I have actually started to do that, and it has shown me results. So if some of us want to consider that, please go through Sabyasachi's talk. I'll probably post the link to you on this MOS webinar group. So it's a very good and a very lucid talk where he explains that how things work in diabetes.
So but there are certain concerns about his approach. We can discuss that later. Yeah.
No, I agree, Rohit. I'll just make a summarize this, but very absolutely lovely talk with the holistic approach. It was an expansion of what we learned as fellows from Ajit Babu sir about monitoring cholesterol and looking at the lipids. Now, what's important over here is you can't restrict your carbohydrates and just concentrate on fats or proteins. The reason being that we don't have enough data regarding the same. All these kind of different diets do definitely bring down your blood sugar levels, but we don't have long-term data. So I think we can have a separate talk on that later. And now we'll move on to our final talk before we shift to our expert panel. So Dr. Pritam sir, can you please share your screen?
Yeah, thank you so much. I'm so sorry for the hiccups.
The most anticipated talk, sir.
There were some security settings on my computer which had gone a little wonky. So can you see my screen?
Yes, sir.
Yeah. So I'm going to speak on vitrectomy. Oh, sorry. I think 1 second. Again, I'm sharing the wrong presentation. 1 second. No. I think this is the evening of faux pas. I think I've taken the wrong presentation from that computer to this computer.
So if you can fix it in the meantime, perhaps we can
give me 2 minutes. Give me just 2 minutes.
We
Sure,
can have question and questions, or we can take inputs from the panel. Piyush.
So can I point something? What is the take of the panelists on since we have advanced in diabetic vitrectomies because of the visualization systems and the machines, etc.? What is your take on the vitrectomy? I would say early vitrectomy in diabetics. Any inputs on that? Does anyone practice that?
No, I would not operate a patient with 6669 vision, in diabetic vitrectomy, however lucrative it may be. Because I have had in 35 years patient who had very low vision, recovered very well in other eye, suddenly lost, because of diabetic vitrectomy, because it is one vitrectomy which cannot be taken lightly because vitreoretinal anatomy you can never predict totally. So I would be hesitant to operate patient with 6/9, 6/12 vision unless patient is deteriorating.
So,
your comments on this?
Sir, vision may not be the only criteria. There may be certain points which will point towards the vitrectomy. Suppose if you have vessels which are still on the surface of the retina and they are not, or they are even slightly elevated, where a vitrectomy may be better off, where the fibrous component, if you inject anti-VEGF or laser, may increase. There are certain points that we should take into consideration.
No, I would still be skeptical unless there is a combined retinal detachment,
Pritam is ready with his.
Yeah. Shall I? Okay. Thank you so much. So my talk is on diabetic vitrectomy. So I have a few pearls about diabetic vitrectomy. Now, the indications for vitrectomy in proliferative diabetic retinopathy essentially is non-resolving or organized vitreous hemorrhage, where you waited long enough for the vitreous hemorrhage to resolve and it's not resolved, so you need to go in and remove the vitreous hemorrhage. When there is a retinal detachment, the retinal detachment could be tractional retinal detachment involving the macula, the classically textbook description of tabletop TRD, or it could have had a retinal break, a tractional RD with a retinal break, which has become a combined retinal detachment. Now, one cannot undermine the role of anti-VEGF to help in diabetic vitrectomy. It is a game changer. One can use Avastin, Zaltrap, Ranibizumab. It is injected intravitreally, preoperatively. And in my practice, I usually plan the vitrectomy about 2 to 3 days following the injection of anti-VEGF. Of course, the rationale of anti-VEGF is to reduce the vascularity of membranes, making the surgery less bloody and less difficult. It's easier to dissect the membranes when they are less vascular, and there is better chance of hemostasis. When that happens, there is lesser chance of having iatrogenic breaks, because most of these iatrogenic breaks usually happen when you're trying to clear the pre-retinal hemorrhage, is when those iatrogenic breaks happen. One is very important is the role of ultrasound. If you have access to an ultrasound or you can refer for an ultrasound, one must do an ultrasound. That helps to assess the status of the retina when you're not able to know whether the retina is detached, whether there is a tractional RD behind the vitreous hemorrhage. That will help you to plan the surgery better. It will help you to explain the prognosis to the patient, because a macular TRD, you're going to tell the patient, you're going to give the patient a guarded prognosis. On ultrasound, you also have to look for, whether there is PVD, whether there is vitreochiasis. It also tells you about subhyaloid hemorrhage, and all these features help in planning the surgery. So these are a few pictures of, you can see the one on the left-hand corner top, a vitreous hemorrhage with a complete posterior vitreous detachment. Now this makes life a bit easier in diabetic vitrectomy, because there may be lesser membranes here to dissect, and this will be an easier surgery. Now there is on the right hand top corner, you see a single focal tractional RD. The vitreous is attached to that tractional RD. There is subhyaloid hemorrhage between the posterior hyaloid phase and the retinal surface. This also would probably be a relatively easy case. This side, right hand side lower corner, is a subhyaloid hemorrhage. You can see the vitreous gel is echolucent, but there is echos in the subhyaloid space. This would be really a bugbear. You can see like a tabletop tractional RD on the left hand lower side corner and the vitreous attached to it. This will be definitely a difficult case with probably a lot of membrane dissection to be done and a guarded visual prognosis. The principles of diabetic vitrectomy, like any other vitrectomy, is you need to do as complete a vitrectomy as possible. The rationale is to reduce the vitreous scaffold for any proliferation in the future. Relieve all the traction. You're dealing with a tractional RD, so you have to relieve all the traction. Only then the retina will settle back in place. And for that, as complete and total membrane dissection as possible has to be done. ensure that you thoroughly ablate the retina, because it is the retinal ischemia which has caused all these problems, proliferation and RD. So the retina has to be ablated. And lastly, achieve optimal hemostasis by the end of surgery. Flattening or settling the retina if there is a combined or tractional RD is important. One may need silicone oil tamponade in cases of combined RD. Silicone oil tamponade also helps, in those cases where, let's say, you have a lot of pre-retinal heme at the end of surgery, to compartmentalize the heme and not allow it to come probably into the anterior chamber, cause hyphema. Silicone oil helps, and that can be removed at a later date. Whether to put a band or not, that could be decided intraoperatively based on how the surgery goes. Now, modern vitrectomy has really changed our success rates, and our ease during surgery. The biggest, I think, advancement has been the trocar cannula system, or the MIVS, where I think it really helps in facilitating peripheral vitrectomy. In the past, we used to suture the infusion cannula, and that was it. We had access only to 2 superior ports. But with MIVS, like here, I'm struggling to do vitrectomy in the inferior quadrant, and all I have to do is just take my infusion cannula from the inforotemporal, bring it to the superotemporal place, and I get access with my cutter from the inforotemporal port, and then I depress the 6 o'clock sclera, and I can easily clear and do a good complete vitrectomy at the 6 o'clock position. You can see I'm clearing the vitreous hemorrhage present inferiorly. So this is an advantage which the valved or the trocar cannula system has offered us. Also, the high-speed small gauge vitreous cutters have made life much easy. The high cutting rate, the duty cycle option that we have, these things decrease the surgical time because of the high cutting rate. There is safety from complications because of a duty cycle option, and there is lesser chance of iatrogenic retinal break, especially in a detached retina. The small gauge and the augmented tips have made it very easy not only to shave the vitreous but also to do membrane dissection. So when I say port optimization, what I mean is not only has the cutter become small in size, but as you can see, the opening of the cutter has gone more distal. So one can actually do the membrane dissection with the cutter itself. Of course, one always has, in your armamentarium, you do have vitreous forceps and scissors, but large membrane sheets of membranes like these also can be cleared with the help of a cutter, because the port is really close to the tip, and you can easily achieve segmentation with the help of the cutter itself. The other option is, because of port optimization, you can have the membrane rolling into the cutter. This is a reverse membrane roll of the membrane into the cutter. So you can simply stay over the cutter and allow the membrane to roll into the port of the cutter. This way, there's lesser chance of touching the retina, causing iatrogenic break. Many a times you can use the cutter itself to create pre-retinal heme. Of course, you have your other instruments also to do this particular step. In case of breaks, you can do a fluid air exchange, endo drainage with these port optimized cutters. There are other advances in techniques and instrumentation like chandeliers, better illumination, wide angle viewing systems. We have chromovitrectomy, like using triamcinolone or OcuBlue if you want to peel the ILM in diabetic macular edemas, better tamponades, and of course all better instrumentation. Bimanual vitrectomy again is very important because in this case it gives you a better chance of doing a thorough and a more efficient membrane dissection. One must remember that the timing of deciding bimanual vitrectomy is very critical. Preferably, if on ultrasound, if you see a tabletop TRD and you take a decision, I think that would be the best time to decide that I want to do bimanual even before you start. Maybe the second option, plan B, would be after doing a core vitrectomy and truncating the vitreous, you look at the large membranes and you take a decision that, okay, it will be better to do bimanual rather than, doing a unimanual technique. But one must not be too late in doing a bimanual, because once it starts bleeding, once the blood goes between the membrane and the retina, then it becomes very difficult to dissect the membranes. long timing of the surgery will cause corneal edema. You may end up with iatrogenic breaks. Your retina starts lifting up. Then it becomes too late, the decision of converting to bimanual vitrectomy. This is a video again of bimanual vitrectomy, and it just goes to show how long we have come. This is a video from 2005 when I'm using a illuminated infusion cannula, and I'm using Lander's contact lenses and doing bimanual dissection. But even then, I'm using a forceps and scissors to dissect membranes over a combined retinal detachment, as you can see over here. You can see the ischemic retina and a lot of sclerosed vessels underneath. And then now, this is a recent video where, you have very good chandelier systems. You have your trocar cannula systems. So you simply insert an additional cannula, trocar cannula. In fact, I use sometimes two of them. I put one inforotemporally and one supranasally. So I can even shift my chandelier from one side to the other, depending on how the membrane dissection is going on. And it really allows you good illumination inside to do a good delamination and segmentation. One has to remember that we have to deal with recurrent vitreous hemorrhage many a times in these cases. If there is a recurrent vitreous hemorrhage, you have to work up the case, do an ultrasound, make sure, look at the status of the retina, whether the retina is attached. One may need to do a UBM to rule out what is referred to as AHFPP or anterior hyaloid fibrovascular proliferation, which typically could be at the site of the sclerotomies. Usually, a recurrent vitreous hemorrhage can have three possible conclusions. It might spontaneously resolve, and then all you need to do is further ablate the retina, do some more pan-retinal photocoagulation so that the proliferation doesn't bleed again. The second option is, if it does not resolve, you could give anti-VEGF and again ablate once it clears up. And the last option, if that doesn't clear up, then you may have to do a vitreous lavage and the works, probably put in oil. But as you can see, the common factor here is ablation. So whatever you do, once the hemorrhage clears up, you have to make sure that you've thoroughly ablated the retina and done a good pan-retinal photocoagulation. So with that, I think I've covered most of the topics here. Thank you.
Yeah, Thank you, Dr. Preetham. That was a wonderful talk, all encompassing. So I would like to ask Dr. Pramod Bhende sir to take us through how you would guide us through the diabetic vitrectomy parts. As we all know, sir is teacher to all of us, and even now I'm sure even now Dr. Preetham refers to sir when there are cases.
I was going to put it in my presentation. I remember Dr. PV sir saying that keep your diabetic vitrectomy either as a first case in the morning or the last case in your list, because first case you're mentally fresh, or you better have it as a last case where you're mentally relaxed, because the rest of the list is out of the way.
Correct. So that's what I said. Even Dr. Preetham still refers to sir when he's stuck somewhere. So, sir, pearls of wisdom from you as far as diabetic vitrectomy is concerned.
So you'll have to unmute, sir.
Okay.
Yes, sir.
Yeah. Thank you very much for having me here, and excellent presentation. I think all the presentations were very good. I think everybody is very well prepared. And let me say, Preetham and everybody, I'm really proud of you people. Like, I hardly have to add anything now. Okay, I cover most of the topic, yes, but the previous question, what he has said is, with the MIVS, with advances, surgeries have become relatively safer, much safer than what we used to see, less time consuming. But yes, indications probably still remain same. Only thing is, previously we used to wait much longer period for a hemorrhage to clear. or we used to wait for vision to go down significantly because results were unpredictable. Now, because of safety, we are relatively, I would say aggressive may not be the right word, but we feel much more comfortable and confident to deliver better results. And that's why probably we are on early surgical intervention than the waiting for vision to really go down. I think, yeah, advantages again, you can change the sclerotomy locations. You have your chandelier illumination. So in a true bimacular vitrectomy, what we talk about now, it is possible. But overall indications, I think over last so many years, not really significant change. I mean, any specific question, I think we can take one by one if necessary. But I think most of the things are very well covered.
My question would be for recurrent hemorrhage following vitrectomy, that becomes a challenging situation many times. After you have done good membrane peeling and we are comfortable with what job you have done, still patient comes with recurrent vitreous hemorrhage. That is one. And secondly, your take on ILM peeling in diabetic vitrectomies.
You're asking me?
Yes, sir. Yes, sir. Your opinion on this?
Yeah, ILM peeling in a diabetic as a routine I won't do. I mean, to be very frank, I know people are doing, but I mean, that's always debatable. But basically, most of the time, what we are dealing with a tractional retinopathy here, and macular hole is probably secondary to either traction or rupture. Your cystoid macular edema, large cyst were rupture. If a cyst rupture, obviously vision-wise it doesn't help. And if it's due secondary to traction, once you relieve the traction, most of the time it settles down. Now, the logic is probably what we talk about. If you remove the ILM, most of the whatever we talk about vitreous schisis and other factors, probably you peel everything clear off. That's the logic. But ILM peeling is not simple as easy as what you see in a conventional macular hole as against diabetic, because if boggy cystic macula, they are very high risk of you are converting partial thickness or cysts into full thickness macular hole. But once you relieve the traction, most of the time this macular hole sometimes closes and it settles down. That's what my take for this part. Okay, recurrent vitreous hemorrhage. I think I follow the approach which Pritham say. Basically, we have a recurrent vitreous hemorrhage. Again, recurrent, you differentiate between recurrent and persistent. Persistent, if you want, you wait for a while, obviously, but my first investigation would be obviously, apart from ultrasound, is UBM. If UBM shows peripheral, what do you say, like a sclerotomy site proliferation or anterior proliferation, probably that is the time you need early intervention. Indirect evidence, again, associated rubeosis or angle neovascularization, and with, of course, attached retina. But if there is no anterior proliferation, no signs of anterior segment ischemia, again, given option, I would wait for a while. And as he has said, almost 80-90% of time, it settles down. And in between small bleeds, first 6 months to 8 months post-surgery is bound to happen. And it's also what we need to ask, fluctuation in a blood sugar level, change in the medications. Patient, suppose started on anticoagulants later on because of some other diseases, those are again prone to have it. But if you have an anterior proliferation or you have a sclerotomy-related problem, and also, obviously, if you have treated the patient earlier, primary vitrectomy, if you know that you did a very good laser photocoagulation, then you can safely watch those patients again. But you are not have past history, operated somewhere else. How good photocoagulation, how good peripheral vitreous-based excision. If those informations are lacking, probably again you are on having earlier intervention. Okay, so if retina is very well attached and have a proliferation along the periphery somewhere, you obviously can give us a chance of trying anti-VEGF, wait for a clearance, and if it clears, then go ahead and add some additional laser or even anterior triopexy. I won't mind doing that still. Okay. But if you have a repeated recurrences, significant amount of anterior proliferation, rather I would prefer to go ahead with a wet lavage, clear everything, clear an ultrasound obviously again will helpful to see peripheral uncut gel, and if that is significant amount, or you have some residual traction, The best way, rather than waiting, best way to go in, clear all those areas, ablate peripheral retina, and I think they will do well.
Thank you, sir.
Jay has a point to make.
Yeah, sir, I just had a couple of more questions. So, first is what would be your choice of tamponade in these patients with recurrent vitreous hemorrhage? And second would be, in which cases would you consider doing a belt buckle also for tractional RDs in these?
Well, tamponade as such, if there is no break, no tamponade. Okay. And again, as between silicone oil or gas, it depends on location of the break. See, once you convert to regmatinous RD, all the principles of regmatinous RD, you use it. So basically, it's not like silicone oil is better versus or gas is better or vice versa. So advantage partly maybe silicone oil, and particularly most of this, quite a few of these patients having a poor vision in other eye. And if you have a silicone oil added on, at least immediately they start seeing something, gas will block the vision. So at least they are mobile, ambulatory, and also you can see under silicone oil that what is going on so many times. I think probably more logical approach is that way rather than silicone is better over the gas. No, I won't put it that way. Okay. But if other eye is good, so isolated break somewhere superiorly, I would prefer going with gas, because the moment you have oil, eye is not the same what it is. And eventually you are already signed for another surgery, minimum one more surgery. And bleed under oil are sometimes they are difficult to handle. It can excessive fibrosis and all those things, pre-retinal fibrosis, something reproliferation can be sometimes more difficult to handle than having with gas. That's a way of looking at it. Now, as far as belt buckle, as a routine, we do not need it. But you're a fakey guy, peripheral traction if you have, and you are worried when you try to peel those peripheral traction off, and if I land up in a break. So whatever all effort, energy you have put, your nice dissection you have done on a posterior pole, everything is clean, and just isolated traction peripherally. And if I'm trying to create a break there, I lose all my effort, energy, and also you compromise, once retina is detached, you compromise final outcome. Rather than peeling that off or taking too much, but traction has to be relieved. And those are the situations probably rather than doing aggressive dissection there and creating iatrogenic problem, I won't mind supporting with a encerclage or segmental buckle, depending on how extensive peripheral traction is. But the bottom line is relieve the traction, whether you want to peel the membrane, good vitrectomy, or supporting with buckle. The concept again having a ischemia inducing ischemia because you are adding buckle. Probably unless you really tighten too much, usually it doesn't happen.
Okay. Thank you, sir.
I have one question for Dr. Preetham.
One question that Dr. Ashwin had asked earlier, it was a very pertinent question, which Vatsal sir had answered. And I would also like the other panels as well as PB sir to also give their take on this as compared to what SOPs or protocols we would follow in taking patients up for earlier vitrectomies. Of course, with 25 and 27 gauge, people are taking them up earlier. Have you all seen a change in the kind of patients that you're taking up earlier for surgery in the last decade? Is there any change in a selection criteria? PB sir?
Hello?
Was my question audible? It was Dr. Ashwin Bhavna had asked a question that do you take up any particular patients up for vitrectomy earlier? Any criteria that you're following apart from the whether it is? Am I audible?
I think he's answered that, Piyush. He actually said that what was there before, now the threshold for surgery has reduced because we have been doing it more effectively.
I wanted PB sir's opinion also, and the other panel.
He only said.
No, I think I answered that question partly because yes, we are little bit. We all previously classical teaching used to be there, like wait for 3 months for vitreous hemorrhage to clear. I think we won't wait that much. Also, sometimes visible traction is not there, and if OCT again helps this out. If you have vitreomacular traction, macular edema is not obviously responding to treatment, or sometimes if you know that obvious when you have mechanical traction, your anti-VEGF or steroids may not help to resolve that macular edema, might as well go inside, which previously we never had that information. So probably a little bit change is there. Also, work profile, younger generation. I think those certain indications are same, but yes, sometimes we don't wait that long. now for 3 months or 4 months. Probably in a month or so, probably we'll take him for surgery if he's not clearing. If, of course, a patient is very well, retina is very well laser, and then you have him, you may wait. TRD, if not progressing to macular area, I would still wait. Not necessarily because TRD is there, I'm going to take for vitrectomy. But vitreous hemorrhage, probably we won't wait that long now what we used to previously.
Right, sir. Thank you, sir.
Maybe another situation is, if it's a laser naive retina, and you have a vitreous hemorrhage which is not absorbing.
I agree.
In that situation, because you don't want a neovascular glaucoma and that to happen. So probably in that situation also, I would go in early.
Agree. Absolutely right.
Just one question about the anti-VEGF pre-surgery in diabetic vitrectomy. So, maybe sir, your protocol about the.
Yeah, I won't. I mean, it's not as a routine guide, and it's not like I'm going to use for every case. Not every case, but yes, but it is very, very subjective. Anticipated bleeding, when you see extensive membrane dissection, you anticipate, and if you see fluoride proliferation, and that is a situation you give, but that anticipated bleeding is a very subjective, each one has even, but not as a blanket. Every diabetic before going vitrectomy will have a anti-VEGF injection. But once I decide to give anti-VEGF, but if already fibrosis, you see more like a fibrous proliferation rather than fibrovascular. If you have more like a focal traction, probably I won't give. Okay, but I ensure before giving injection, we will have his systemic parameters controlled very much, and then inject. The ideal window is somewhere around 4 to 7 days. If you want to give, but we all know within 24 hours you see some effect, but you really have a maximum benefit of anti-VEGF, pre-surgery anti-VEGF, probably I would say minimum 4 days we should wait.
I think
but
also
definitely not more than 2 weeks.
Also in cases where you had not had any laser and you're going to operate that patient for vitreous hemorrhage, I think it's definitely important that you have anti-VEGF in the eye before you do the vitrectomy.
Dr. Preetham, in case of an inadvertent retinal break, do you have any experience of using fibrin glue as temporary, as a temporary tamponade? Dr. Mudit Bansal from LV Prasad has used it quite a bit, and he has published also. You have any experience of using it in diabetics?
So that means when you use a fibrin glue, let me understand. When you use a fibrin glue, you don't need any other tamponade. Is that what you're saying?
Yes, that's what Dr. Mudit says.
Let me kind of expand on that. What Mudit Tyagi does and what Dr. Malika Goyal madam has also shown in their cases is that these ischemic retinas which refuse to settle down in these combined breaks, it might be difficult to laser them off. So when you're getting tired, they have used, especially Dr. Malika, she's used fibrin glue over there, and the coagulum itself, she can see settling up on the retina. It is very difficult to laser all around it. If required, they can do it later.
Yeah. So I agree with that. Sometimes laser can be difficult if you've created a posterior break because of few reasons. Like, you could have SRF collecting again and again under it, and then you won't be able to laser it. Or you could have heme collecting over the retina or even subretinally. So it becomes difficult to laser. So here then that you can do two things. You can use PFCL. The PFCL will push the retina towards the choroid and allow you to laser. You could also use endocryo. You have endocryo probes which you can use, and you can ablate the you can do the barrage that you want. What normally you do with endo laser, you could use an endocryo to do it. If there is fluid collecting again and again under the break. So these are some of the things you can do if you are not able to conventionally barrage the breaks which are posterior.
Yeah, basically, what we need to understand is fibrin gives you temporary closure of the break, but it will not cause chorioretinal adhesion. Eventually, that is what you need. Okay. Now, the fibrin glue, how long it will be there, it's little bit unpredictable. It disintegrates. It can be 3 to 5 days. It can be 8 to 10 days. Okay, typically. Okay, and that's a little bit catchier, and that's why it is still not become popular. Otherwise, all of us would have been, laser, basically laser or cryo. Retinopexy is must. But over and above, now add glue, which will help you to hold on, so that probably you do not need as restrictive positioning, cone position or whatever, depending on the location of the brake. That probably will ease out. But there is no alternative to retinopexy. Over and above, you add this, because only if you put just fibrin glue, the moment it disintegrates, your brake is open, your retina is going to detach further. That's what all of us need to understand. It's not like you use it and you forget about it and it will seal. It is not going to seal, whether it's so anywhere, and that's rheumatogenic RD or your diabetic TRD. Now, I think most of newer generation probably, because particularly with 23, 25 gauge vitrectomy, nobody has seen even endocrioprobe. Because that was only with the 20 gauge what Pritham is mentioning. So that is one of the actually useful tool which you can create, even whether it's fluid is there, a blood clot is there. You can at least, I mean, it can be disaster sometimes if you use a cryo inside the eye and you pull it off and it can tear the retina, a heavy reaction. So you have to be very controlled way, but at least you can get a 1 row or 2 rows of cryo application around the brake. Even if there is a blood, it will freeze through and come out, and we can add on additional laser subsequently if you form. Now, looking at a fibrin glue, yes, what you look at is advantages. Probably you put it like a pneumatic retinopexy, you put a glue, still probably want to use tamponade fine, position the patient so that whatever fluid is there, squeeze it away from the brake, maybe a second day, third day, in a week's time, and then go ahead and do laser around it. But only thing is probably you do not know what happened. As long as glue is there, you may not be able to get burn because glue is holding on there, because it sticks from a thick glue, sticky membrane there. And the bind, when it starts disintegrating, by the time you may be too late. It's like a this or that. Sometimes it's a lot of practical issues with that.
If anybody does not have any more questions or comments, if somebody has them, we can quickly make them, or else we'll close for today. So I would like to thank all the speakers, all the panel for spending the entire evening on World Diabetes Day, staying hungry right up to 9:45 at night. Thank you very much from MOS Scientific Committee. From MOS, we've got the Secretary of MOS also who's joined us. Dr. Viral Shah has joined us. So would you like to say something?
Excellent webinar, nice coordination, Dr. Piyush and his team, and all the speakers were fantastic. And hope to continue this series in future also. Thank you so much for conducting such a beautiful webinar on World Diabetes Day.
Thank you, sir.
Thank you very much for invitation.
Thanks to Dynamic Viral Bhai and Piyush Bhai.
Before we
Thank you, sir.
end,
Thank you.
there is a request from Entod. They've been kind enough to sponsor all the webinars. So if we can just play a 30-40 second video from them. So thank you once again to all respected seniors and colleagues for being over here and sharing all your knowledge, trying to compress all of that information in such a short duration of time. Apologies for hastening things. Thank you very much.
Thank you, Piyush.
Thank you, Piyush, and
Piyush, as a scientific chairman, a suggestion that all this valuable, these are like pearls of all these seminars. I hope you're recording it and it's putting it somewhere, for people to later on access it.
Yes, sir. It's being telecasted live right now. It's going. We can access it later on. We can take excerpts from it. Obviously, I'm going to come to you for advice.
It is there on our official channel of MOS, Maharashtra Ophthalmic Society's official YouTube channel, and also it is Facebook Live, so you can go into the Facebook archives of Maharashtra Ophthalmic Society. You will get it.
Nice. Very
Nice.
nice.
You can archive
Piyush sir,
and-
yeah, Piyush sir can send a link of YouTube link to all the members after the webinar is over tomorrow. So, Piyush sir?
Yes, sir. Sure, sir.
Yes. Okay.
Okay, thank you, everyone.
Thank you very much.
Thank you.
Thank you.
Everyone. Thank you, Piyush. Thank you, everyone. All the
Last but not the least, I would also like to thank our excellent moderators, Dr. Manish Papai, who is in a hurry to leave, and Dharmesh Kar. Thank you so much, both of you all.
Well done, Manish and Dharmesh.
Fantastic work
Thank
by
you.
Dharmesh and Manish.
Thank you.
Thank you, everyone. Thank you. Thanks a
Thank you,
lot.
everyone, for the
Good night.
Good night, Dikshit sir.
Good night. Good night.